The committee will come to order. 3 years ago, Congress passed the bipartisan No Surprises Act to end surprise medical bills for good. American patients were in desperate need of these protections as too many had come face to face with medical bills from being treated without their knowledge by an out-of-network doctor. It left them on the hook for tens and even hundreds of thousands of dollars in surprise medical expenses. This law has seen success in ending that crisis. Unfortunately, the new surprises for patients have come in the form of medical staff shortages, longer wait times, and fewer choices because of the federal government's flawed implementation of the law. 3 years ago, the Ways and Means Committee led the bipartisan effort to draft the No Surprises Act, but agency rulemaking has unfortunately ignored congressional intent. It has created a tilted dispute resolution process that has left medical providers paying more to participate in a process that often forces them to accept artificially low payments with no enforcement guarantee. It has also led to legal challenges that have resulted in significant backlogs and left the process clouded in uncertainty. This law's implementation has made the very problem it intended to fix worse, resulting in more medical providers no longer covered under health insurance networks. This leaves Americans paying more to access fewer doctors than ever before. All of this makes it harder for patients to access quality care as healthcare facilities struggle to even keep their doors open, particularly in rural areas. Consequently, emergency room wait times have doubled since 2020. The rules implementing the No Surprises Act have inflamed an existing staff shortage in an industry where having too few people can be a life and death matter. Right now, 600 rural hospitals are at risk of shutting down. Left unchanged, these federal rules will continue to lead to less access to quality care. Patients are the ones most impacted by closed hospitals and long wait times for critical services. Rural and urban areas both face a healthcare shortage. At the same time, the agencies have not bothered to implement the advanced explanation of benefits, one of the key reforms that members of this committee fought to include in the No Surprises Act. Part of ending surprise billing is ensuring that people know the price of healthcare services before they walk in the door. Before a patient sees their doctor, patients should be told how much they'll pay for the care they receive. And yet patients still have yet to benefit from this protection to which they are legally entitled. While Congress made strides in stopping surprise medical bills, the fallout of this law's implementation demands our oversight. And I'm encouraged that there is interest from both parties in seeing this bipartisan law fairly implemented. It's unacceptable that a major win for Americans can be turned into a scenario where medical providers struggle to keep their doors open. Patients lose access to quality care, and the basic principle of knowing the price of the care they'll receive has yet to be realized. I look forward to working with my colleagues on both sides of the aisle to make the promise of the No Surprises Act a reality. And I'm pleased to recognize Ranking Member Mr. Neal for his opening statement.
Thank you, Mr. Chairman, and I'm pleased that you've called this hearing this morning, and I want to thank our witnesses for being here as well, and I certainly look forward to hearing from all of you. I know what Kevin Brady and I intended when we helped to write this law, and the implementation so far has been a disappointment, despite the fact that we continue to prevail in court decisions. For too long, millions of Americans have struggled with unexpected out-of-pocket health costs that has caused anxiety and hardship for their families. When we wrote this law, we weren't targeting anybody, we weren't looking for a victim, and we weren't being punitive. In 2020, the Ways and Means Committee expanded our long legacy of patient-first policies, leading the charge to end the uncertainty of surprise medical billing. We brokered the No Surprises Act, putting an end to surprise medical billing while enhancing consumer protections and empowering patients with more information about the costs of their care. Unanimously, this committee put out the appropriate version of the legislation. Ways and Means Democrats continue to want what's best for America's patients. That means an accessible, affordable, and transparent healthcare system with robust protections for consumers. The No Surprises Act builds on these priorities, providing for an impartial, structured process to settle payment disputes between insurers and providers, with strong conflict of interest protections, timely decisions, and clear criteria for resolution. Unfortunately, implementation of this law has strayed from Congress and its original intent, especially as it relates to the dispute resolution process. When drafting the law, we worked to ensure fairness between the parties involved in the payment disputes, and we carefully specified factors that should be considered during the independent dispute resolution process. The IDR process was developed through robust, extensive congressional consideration in this committee for 2 years before the No Surprises Act took place. As written, this law carefully avoids any one single factor unduly influencing the dispute resolution process. Despite this consideration, the final rule for the No Surprises Act strays from the law as written in favor of an alternate approach that overwhelmingly favors one factor instead of the more balanced consideration that this committee and Congress fully intended. Democrats have fought to bolster patient protections and build a healthier, stronger America. We delivered this historic Affordable Care Act, and now we're raising the first generation of Americans who didn't know a life without patient protections and the access that we provided that came through the Affordable Care Act. Now more Americans have health coverage than ever before, and Ways and Means Democrats are committed to building on the progress that we've made by continuing to lower health care costs and to promote price transparency. That's why we delivered the No Surprises Act, again in a bipartisan manner, and we will continue to work closely with the administration to ensure this law is implemented as this committee and as Congress intended. It's time to get this back on track and ensure that one of the greatest consumer protection reforms in our country's history is fully implemented as the Ways and Means Committee intended. With that, Mr. Chairman, I yield back my time.
Thank you, Mr. Neal. I will now introduce our witnesses. Dr. Bleier is the Vice President of Finance at the Wake Emergency Physicians Professional Association. We have Mr. Bobek is the President of Federal Hearings and Appeals Services. Ms. Spicer is the Supervising Attorney at Community Health Advocates. And Ms. Thornton is the Executive Vice President of Policy and Strategy at America's Health Insurance Plans. And Mr. Budzinski is the Executive Vice President and Chief Financial Officer of Wellstar Health System. Thank you all for joining us today. Your written statements will be made part of the hearing record, and you each have 5 minutes to deliver your opening remarks. Dr. Bleier, you may begin when you're ready.
Chairman Smith, Ranking Member Neal, and members of the committee, thank you for the opportunity to testify today in this hearing on the implementation of the No Surprises Act. I'm an emergency physician from Raleigh, North Carolina, and I currently serve as the Vice President of Finance for Wake Emergency Physicians PA, or WEPA. I am also a member and fellow of the American College of Emergency Physicians, ACEP, which represents nearly 40,000 members, as well as the North Carolina College of Emergency Physicians. On behalf of our practice and our specialty as a whole, we appreciate the committee's ongoing commitment to ensuring the law is implemented fairly and according to congressional intent. Wake Emergency Physicians is an emergency medicine practice serving central North Carolina. Since our founding in 1992, we have always been physician-owned and have never had any corporate or private equity backing or interests. Every owner regularly works in the emergency department. WEPA currently employs more than 200 dedicated emergency medicine specialists comprised of about 120 residency-trained, board-certified emergency physicians and 95 advanced practice providers. We serve in 11 different emergency departments across 4 different hospital systems in the region. 4 of those emergency departments are located in rural communities. Our goal is and has always been to be in network with every payer. And until the first regulations for the NSA were issued, we were in network with all 4 major insurance carriers in our area of the state. To be clear, the No Surprises Act is a critical bipartisan accomplishment that removes patients from the middle of billing disputes between physicians and insurers, and we strongly supported this goal. In an emergency where seconds and minutes are often a matter of life or death, patients should never have to think about their insurance coverage or whether they will receive a bill that they did not expect. Beyond these important patient protections, the law established an equitable solution to resolve billing disagreements, at least in intent. Unfortunately, the implementation of the law to date has proven to be exceptionally challenging for smaller practices like ours. While we have so far been able to weather some of the impacts, if these challenges are not resolved, we are deeply concerned that practice models like ours may not be viable in the near future. And access to life-saving emergency care may be severely affected, especially for rural and underserved patients. As I noted earlier, WEPA had historically been in-network with all major carriers in our region of North Carolina. Most of these contracts had been in place for at least a decade without any changes or updates. In November 2021, we and many other physician groups in the state received a letter from one of these insurers demanding significant cuts to our contracted rate. The letter explicitly cited the interim final rule on the NSA as justification for the reduction and stated that if we did not agree to new payment terms, our contract would be terminated. Thankfully, this did not come to pass, but we have since had 2 other payers unilaterally terminate a longstanding contract. These insurers are now paying at rates that are up to 70% less than our previous contracts for what are now out-of-network services. This is just not sustainable for a practice like ours, and if these conditions persist, we may be forced to substantially reduce staffing hours, cut positions, or potentially even withdraw contracts at certain hospitals. Adding to this burden is the fact that the IDR process has been virtually inaccessible for small practices once we are out of network. Many smaller practices have been advised by their billing contractors to avoid going through the IDR process altogether, as the costs outweigh any potential benefit. We cannot afford to challenge every underpayment when the non-refundable portion of the arbitration fee is $50, much less $350. Even though the government statistics show providers prevail the majority of the time over insurers in IDR, to date, we have only submitted about 400 IDR claims. Batching rules, the IDR processing backlog, and cases where payers are simply not paying at all have also contributed to the substantial burden. Now that at least some of these issues have been resolved due to recent court decisions and the resulting pending regulatory changes, we do hope to re-engage with the IDR process when the portal reopens. But all of this takes up valuable time and resources that we would much rather devote to patient care. We would rather not be forced to submit IDR claims. We want to go back to being in-network with every payer, and our long-lasting contracts in place prior to passage of the NSA show that we always did our best to be in-network. WEPA is only one practice, but sadly we know our experience is not unique. We believe the No Surprises Act clearly struck a delicate balance as to not tip the scales too far in favor of any party, but the regulations have not been consistent with the law that Congress passed. Thank you once again for your attention to these issues and for the opportunity to be here to share our experience. I look forward to any questions you may have.
Thank you. Mr. Bobeck, you are now recognized.
Chairman Smith, Ranking Member Neal, and members of the committee, my name is James Bobeck, and I'm the President of Federal Hearings and Appeals Services, a certified independent dispute resolution entity, commonly known as an IDRE. Thank you for the opportunity to speak to the committee today regarding the implementation of the No Surprises Act and the independent dispute resolution process. FHAS is a certified veteran-owned small business from Pennsylvania. We are an accredited independent review organization possessing ISO certification. We are a leading provider of arbitration dispute services and healthcare reviews for federal and state agencies. We have adjudicated over 100,000 healthcare disputes in the past year and over 3.1 million decisions in the past 27 years. FHS was one of the first groups certified by CMS as an IDRE entity. The No Surprises Act prohibits surprise medical billing in certain circumstances. Additionally, health plans must make an initial payment to providers based on the qualifying payment amount, which is the median rate for a particular service. If the provider feels that amount is too low, providers can avail themselves of the independent dispute resolution process, and an IDRE will determine the final payment amount. Over the past 2 years, the Department of Health and Human Services, Department of Labor, and the Department of Treasury, collectively known as the departments, have promulgated federal rules implementing various provisions of the No Surprises Act. Most notably, the departments issued rules regarding how an IDRE should adjudicate payment disputes. The program rules are determined solely by the departments, and the IDREs are required to follow those rules in carrying out their designated functions. Most importantly, these functions include adjudicating payment determinations based upon the parties' submitted offers and supporting evidence. Notably, the IDRE must choose either the provider or the payer's submitted offer, which is commonly known as a baseball-style arbitration. The department published their latest statistics on the IDRE process on April 27, 2023. Those statistics cover the time frame from the start of the process back on April 15, 2022 through March 31, 2023. In that time, disputing parties initiated 334,828 disputes. Entities rendered payment determinations in 42,158 of those disputes. FHAS alone issued 13,500 determinations in that time frame, which represents about 32% of the overall payment determinations. Additionally, 39,890 cases were ultimately determined ineligible for the IDRE process. Ineligible cases primarily resulted from parties' noncompliance with the department's batching rules, which are rules regarding how parties can combine multiple cases into one dispute. IDRE entities also close disputes for other reasons, such as the parties may come to a settlement of the matter or they simply withdraw their case. Throughout the past year, federal court rulings have vacated certain provisions of the department's rules in response. We have made on several occasions a temporary suspension of the IDRE program as CMS attempts to formulate new rules regarding that process. Currently, the dispute resolution process has been suspended since August 3rd, 2023. And during this suspension, parties cannot submit new cases through the CMS portal, and IDREs cannot adjudicate any payment determinations. The dispute resolution portal must be opened immediately to allow dispute filing. Prior to the shutdown, parties routinely filed in excess of 40,000 cases per month. Providers and payers rely upon the portal's operation to finalize payment determinations. Without payment determinations, parties cannot resolve their disputes, providers cannot receive any payment for their services, and payers cannot render required payments to providers. Thank you for the opportunity again to appear before the committee. FHAS is committed to providing timely arbitration services, and we look forward to a continued engagement with the committee.
Thank you. Ms. Spicer, you are now recognized.
Chairman Smith, Ranking Member Neal, and distinguished members of the committee, thank you for holding today's hearing to examine the impact of the No Surprises Act. My name is Diane Spicer. I work at the Community Service Society of New York, or CSS. CSS has been an unwavering voice for low-income New Yorkers for over 175 years. CSS administers the Community Health Advocates Program, New York State's designated health insurance consumer assistance program, through a live answer helpline and in partnership with over 20 community-based organizations located throughout the state. Since 2010, Community Health Advocates has helped over 500,000 New Yorkers enroll in and use health insurance, negotiate medical bills, and otherwise access free or low-cost health care, saving them $180 million. As the supervising attorney of Community Health Advocates, I've had the unique opportunity to view the implementation of both the New York State out-of-network surprise billing law and the federal No Surprises Act. In 2014, the state of New York passed the surprise billing ban, setting up a baseball-style arbitration that kept the patient out of the middle of payment disputes at the urging of CSS on behalf of a coalition of consumer advocates. CSS was encouraged to see Congress follow New York's model in 2020 and ban surprise medical bills for federally regulated plans. We are grateful for the work done in Congress and in our home state of New York to address surprise bills. Nevertheless, we still field over 20 calls per month from patients with questions. The healthcare system can be extremely complicated to navigate for even the most well-versed among us. Advocates spend a lot of time helping patients understand the complicated rules and processes necessary to determine whether they have received a surprise bill and how to appeal to be held harmless. Prior to the passage of New York's law, CHA fielded hundreds of calls a year from consumers who faced surprise bills. A typical case involved the admission of a client to an emergency room for painful kidney stones. The emergency room transferred the client to the urology department who performed surgery. All of their providers were in-network except the anesthesiologists, leaving the client with a classic surprise bill. New York's out-of-network surprise billing law addressed these classic cases for our state-regulated insurers. We at CHA were delighted to see the enactment of the Federal No Surprises Act because it made additional improvements to what we had already achieved in New York, including providing protections against air ambulance bills, addressing network directory misinformation, affording protections to consumers in federally regulated ERISA plans, and importantly, covering the circumstances of when a provider incorrectly tells a patient that they are in network. Claudia Canfo, a concert pianist who needed neurological surgery, is a classic example of this issue. Claudia did everything right. She found a hospital and a surgeon who were in network, cleared everything with her insurance, and proceeded with her surgery. But her surgeon's office had misinformed her that he was in network when he, in fact, was not. She was stranded with a $35,000 bill. Her situation is now covered by the NSA, which requires providers to issue notice and consent waiver forms in advance of treatment when they are out of network. With that said, our clients still struggle every day with the implementation of our state law and the NSA. Specifically, the structure of the law leaves patients vulnerable to surprise bills in several ways. First, the process of determining which bills are covered and appealing a surprise bill is too complicated for many consumers to understand. Second, plans do not automatically hold consumers harmless for surprise bills, and many healthcare providers remain uneducated about the law and continue to balance bill patients. And third, providers may use the notice and consent form inappropriately. Loopholes also remain in the law. For example, there have been operational issues with the rollout of the notice and consent form waiver. We have seen instances where providers use the consent form inappropriately. For example, in a recent case, a consumer whose primary language was not English was told his varicose vein surgery would not be performed unless he signed the form. Because he needed surgery and did not understand the form, he signed the form shortly before surgery and paid a $6,000 deposit out of pocket. His plan's explanation of benefits later stated that his claim was reduced, and because of the protections of the NSA, he would owe only his in-network cost sharing of $18. However, the patient already signed the form, and thus it was incorrectly required to pay. It will be hard to reclaim this amount. All of us sign numerous pages of forms when we go to the doctor and get procedures, sometimes on electric devices, and few of us have the capacity to understand the ramifications of signing the form. I would like to close by saying we're deeply proud of the work we do. Patient confusion around healthcare costs continue to grow, despite federal and state protections. We urge Congress to work together to restore funding to vital health insurance consumer assistance program so that together we can help improve the patient experience and help them through the very complicated processes of determining whether or not they have a surprise bill and appeal to be held harmless for that bill. Thank you.
Thank you. Ms. Thornton, you are now recognized.
Good morning, Chairman Smith, Ranking Member Neal, and distinguished members of the committee. I am Jeanette Thornton, Executive Vice President for Policy and Strategy at AHIP. I testified here in May 2019 as this committee and others in the House and Senate were debating legislation to end the practice of surprise medical billing. As I said then, every American deserves affordable, high-quality coverage and care, and surprise medical billing was a barrier to that goal. At that time, approximately 1 in 5 emergency department visits resulted in a surprise bill. Going to the emergency department or being treated at the hospital meant uncertainty and worry, not only about your health, but also that you'd get an unexpected bill that you couldn't afford. Enacted with strong bipartisan support in Congress, the No Surprises Act has resulted in peace of mind and financial security, but the promise of the No Surprises Act has not been completely fulfilled. Work remains to improve the dispute process, lower healthcare costs, and grow the number of in-network providers. It is first worth reflecting on how far we have come since the No Surprises Act was passed. The No Surprises Act has prevented 1 million surprise bills per month. To put it simply, that's 20 million bills since January 2022. Patients in every state are protected from most surprise medical bills. Billed charges, often exorbitant amounts, no longer dominate as the payment demand for out-of-network care. Patients see lower and more predictable out-of-pocket costs because of the qualifying payment amount, or QPA, is based on the median of market rates. There is more good news. For nearly 9 in 10 out-of-network claims subject to the law, the No Surprises Act works without issue. An initial payment is made by the health plan to a provider or hospital, typically based on the QPA, and this amount is accepted without any dispute. The dispute process was meant to be a backstop, a recourse for providers and hospitals to utilize in limited instances where market rates for healthcare items and services may not be applicable. But today, this process is costly, inefficient, and heavily weighted in favor of initiating parties, with them prevailing in 71% of disputes. We share your frustration in how the dispute resolution process has rolled out. More cases have gone to IDR than were ever contemplated, 14 times more, highly concentrated in just 5 states. Providers are submitting claims that are ineligible. The overwhelming majority of claims are from a small subset of physician staffing and billing companies and one air ambulance company. Repeated litigation from the Texas Medical Association and others has created uncertainty and caused repeated starts and stops and hindered the regulators in developing a process that works. Our goal is to have more healthcare providers, particularly facility-based providers, join plan networks so that this IDR process is rarely used. The success of our business model depends on having large networks of high-quality, high-value healthcare providers. A lack of sufficient information has at times delayed payments, but despite claims to the contrary, this is not intentional on the part of health insurance providers. In fact, withholding payments really works against our business model. We encourage the regulatory agencies to continue their work to ensure the federal process is efficient, reduces ineligible claims, and facilitates on-time and accurate payments. It is critical that unbiased IDR entities are evaluating factors in a uniform and transparent manner that aligns with the intent of the law. Thankfully, today, patients no longer have to worry about receiving a surprise medical bill when they return home from the hospital or emergency department. And for when this does happen, we believe there is a path forward to make this dispute process work as intended in a way that reduces healthcare spending if all stakeholders work together. Thank you for the opportunity to testify. AHIP and our members appreciate the continued bipartisan commitment to protecting patients from surprise medical billing and lowering healthcare costs.
Thank you. Mr. Budzinski, you are now recognized.
Thank you, Mr. Chairman, Ranking Member Neal, distinguished members of this committee. Consistent with the introduction, my name is Jim Budzinski. I'm the Chief Financial Officer of the WellStar Health System from the great state of Georgia. The WellStar Health System is a not-for-profit, community-based, 11-hospital system serving 1.5 million Georgians. The WellStar Health System operates
Could you just pull the mic a little bit closer?
Yes, sir. Thank you. The WellStar Health System operates 6 of the state's 20 busiest emergency departments. We provide more uncompensated care than any other system in Georgia, totaling nearly $1 billion in our last fiscal year alone. WellStar supports the No Surprises Act, which protects patients from surprise emergency room bills. However, we appreciate the opportunity to share with you the unintended consequences of implementation of the Act, which have negatively affected the people and communities whom we serve. Health plans have been able to narrow their networks such that their enrollees often no longer have access to in-network emergency care in many of our communities and rely on a broken system to lower reimbursement to hospitals below sustainable levels. One of our biggest problems with the implementation is the broken independent dispute resolution process, which significantly disadvantages hospitals and health systems. The problems are the result of regulatory interpretations that have biased the process in favor of health plans and bogged it down such that there is a long wait time for adjudication of submissions. For Wellstar, the IDR entities have resolved only 7% of our roughly 8,000 requests for determination. The estimated reimbursement on our request exceed $40 million. Funds owed to us by some of the largest health insurance companies in America. At this rate, it will take over 20 years to resolve all of our outstanding requests. We are also concerned that the implementation of the Act has also encouraged bad insurer behavior. Now, without consequence, insurers are able to sell insurance in counties in which they have no in-network hospital emergency departments. While the Act intended for hospitals and insurers to work together for appropriate reimbursement, health plans are ignoring this provision of the law and regulations. For example, one national insurer with whom we are out of network reduced our reimbursement by nearly 50% immediately after following the implementation of both federal and state surprise billing laws. This change represented a $50 million reduction in reimbursement to our organization. Further, another national insurer recently threatened to terminate our 20-year-plus contract unless we agreed to a 20% decrease in payment. This demand would represent a reimbursement loss of over $4 billion over the next 10 years. At a time when our cost of care has increased because of the pandemic over 25% due to workforce shortages and increases in supply and drug costs. While we were able to resolve this matter with only a $1 billion cut over the next 10 years, this emboldened behavior by insurers is not unique to Wellstar, and it is one of the reasons for the median health system operating margins being negative as reported by Standard & Poor's just last month. For Wellstar, these cuts in emergency reimbursement jeopardize the services we provide to our communities, including those sole community hospitals in our system, some of which now operate at deficits of $14 to $19 million annually. This result was not the intent of Congress when it passed the Act. Mr. Chairman, Ranking Member Neal, members of this committee, we have appreciated the opportunity to share our thoughts with you today. Our time together here is limited, so I would refer to our written testimony for more information. This concludes my remarks, and I'd be happy to take any questions. Thank you.
Thank you, sir. We'll now proceed to the question and answer session, and I will begin. Dr. Bleier, one of the areas of fallout that we have seen from the flawed implementation of the No Surprises Act is how the regulations incentivize health insurers to limit the number of physicians with whom they have contract agreements to cover their services. What does that do for patients' access to care, especially for those living in rural and underserved areas who already suffer from a lack of care options?
It makes it much more challenging for those patients as well as the providers taking care of them. If physicians are excluded and become out of network, basically that reduces their reimbursement, and their reimbursement is what covers the staffing hours, adding additional provider coverage to those needing emergency departments. And by reducing physician hours, emergency medicine provider hours, that reduces the care that those patients need. So it has a downstream effect, unfortunately. Without that additional reimbursement, we aren't able to potentially provide the same level of care that we ordinarily would want to those rural emergency departments who are already suffering for a number of different reasons.
Mr. Bobek, as an independent dispute resolution entity, you have a front row seat to how this process is operating. We've heard concerns about how the law's implementation has complicated the dispute resolution process and has contributed to a backlog of claims. How has this process gotten off the rails, and what can be done to ensure that dispute resolution ultimately is fair for all parties?
Mr. Chairman, three big things that we'd like to say at the beginning are, when it comes to some of the matters regarding the implementation and then how it moves along the process, the words misunderstanding, miscommunication, and then misinformation. Parties not understanding how the process was intended to work, miscommunication among the parties about the information they need to provide each other to even try to get to reasonable offers, and then ultimately the misinformation that occasionally goes out about how they just actually put cases into the system. The biggest thing that could happen, and it is starting to happen right now, is that parties are getting much better at formulating their responses, communicating with each other, and then ultimately getting more cases eligible for the process and decisions being made. Right now, this process still is in its just over 1 year that it's been going on. It was set up for a certain amount of cases, and certainly that's gone overboard. But at the same time, it is set up to move forward on this, and parties, providers, and the IDREs are working much better together to get cases moving along.
Mr. Budzinski, emergency department wait times have more than doubled since 2020, and more than 600 rural hospitals are currently at risk of a closure. As a hospital administrator, how have you seen the implementation of the No Surprises Act affect the ability of hospitals to maintain appropriate staff and critical emergency services for patients?
Thank you, Mr. Chairman. There's no question that the implementation of the Act has had impacts on organizations such as ourselves. The impact reduces resources, and administrators then have to allocate their scarcer resources to staffing and other activities. So there clearly is a direct correlation. Whenever resources are reduced, then the allocation of those reduced resources impact care in some way, shape, or form.
Ms. Spicer, thank you for your work helping patients understand our complex healthcare system. 3 or more years ago, patients across the country would still be receiving surprise medical bills. You have seen firsthand how the No Surprises Act has largely protected patients from this practice. While the implementation hasn't been perfect, can you speak to how the law has benefited patients?
Thank you, Mr. Chairman. The law has benefited patients tremendously. It goes beyond many states didn't have surprise billing laws before the NSA, but the NSA goes even beyond the protections that are in your average state surprise billing law, as in New York surprise billing law. Many of the cases that I had on my helpline prior to the No Surprises Act were cases that were unaddressed by New York's law, specifically network directory misinformation. When you call your health plan and you ask them who's in network, or you look at their online directory and the information is outdated, hundreds and hundreds of cases of consumers who just get bad information from providers or plans about the network are now protected. And so many more protections in terms of air ambulance, also the resolution processes, though complicated for consumers to avail themselves of, are available for them to appeal surprise bills and even go through the internal appeals process and to external appeal with those bills.
Ms. Thornton, the rulemaking surrounding implementation of the No Surprises Act has been subject to multiple legal challenges. This has naturally disrupted the dispute resolution process, delayed payments, and thrown a blanket of uncertainty over the whole law. How are health insurers doing their part to alleviate the current backlog of claims and ensure that payments are made in a timely manner?
Thank you for the question, Mr. Chairman. You are definitely correct. All of the repeated starts and stops from the litigation as well as the changes in regulations have really created a lot of uncertainty with health plans with regard to how they have to plan their staffing and operations for when the arbitration process comes back online. There is also a concern that when the process does go online, there have been such a large backlog of cases that we will not be able to meet the required deadlines and payment timelines because there is such a backlog and so much within the system. And finally, we are really concerned around what the updated rules will look like and whether that will mean that the process becomes more unbiased towards more biased towards the providers versus the health plans. I think our goal is a very balanced process. We'd love to see a 50-50 outcome, right? Some cases we decided with providers, some to plans, and that means the process is working well.
So how are health insurers ensuring that payments are made in a timely manner?
That is a really important question, and we understand how important for providers and their cash flow that they're getting paid in a timely manner. One of the really important things about the Act is that you built in the requirement that we have to make an initial payment within 30 days. So providers are getting paid upon receipt of a claim within 30 days. I think what's often at issue here is how quickly health plans are making payments as a result of an IDR decision. As I said in my statement, there have been at times delays in those payments, and that really has to do with some challenges with the implementation technology, as well as very difficult deadlines and having to go through, in some cases, thousands and thousands of lines of code, match it up to our systems, and then make those payments on time. But we are certainly really strive to meet the deadlines that are provided.
Mr. Neal is recognized for questions.
Thank you. Before I begin my opportunity to question our witnesses, I want to take a moment to remind members of the committee of the role that this committee played in ensuring that Congress would pass a strong and balanced law, emphasis on balanced, and that's what we did. The idea was, almost like binding arbitration, to make sure that people of goodwill and good intentions would try to avoid the process at the end, and it would bring them to a better decision-making process at the beginning. This was done in a bipartisan manner, and it unanimously passed this committee. It was a good product that passed out of here because of the work of this committee and the product that became law. Dr. Bleier, I've heard from many providers across the country that implementation of the No Surprises Act has led to financial uncertainty. While HHS revises the regulations to comply with the law as enacted, other peripheral issues are causing financial difficulty. As with implementation of any new and sweeping law, there are certainly growing pains. I've been pressing HHS at the top all the way through the members of the staff on many issues. So beyond the need to revise the standard in the dispute entities that are trying to comply with the law, can you summarize what other issues in the No Surprises Act are affecting payments to the wake of emergency physicians?
Sure. We had been in network, as a reminder, with all of the major carriers in our area for years. We never went back to them and asked for an increased rate. Our contracts did not have any cost of living indexes, no inflationary adjustments year over year. They were tied to Medicare fee schedules from years before that. In addition, we've also seen significant decrease in payments from some insurers over the years, not only due to inflation, but also due to the fact that a lot of the healthcare expenditures are being pushed to patients in high deductible plans. Despite that, we never went back and asked for more. We have always intended to be in network with all of these providers. Then, with all of these insurers, excuse me. Then the No Surprises Act comes out, and suddenly we are getting letters from insurers saying, you're out of network unless you take a 40% reduction, sometimes more. Since the passage of the law, we've been kicked out of network unilaterally by 2 different insurers and are seeing reductions in reimbursement from one of them by 70% from our previous contracted rates, which we believe were very fair at the time, because at no point up until the No Surprises Act came out did any of the insurers come back and ask for us to adjust our rates. They were evergreened year over year. So because of the No Surprises Act, we've subsequently been kicked out of network. We've seen a tremendous decrease relative to what we believe were fair market rates. And in addition, there's no recourse for action due to the IDR issues that have been ongoing. So even when we win an IDR case, we effectively lose due to the fees associated with it, and then we do not get paid afterwards.
Thank you. So our intent here was not to be punitive, not to pick on anybody, and not to favor one side or the other. It was, as I indicated, a balanced piece of legislation, I think, that provided ample opportunity to all sides of the dispute. So, Ms. Spicer, let me thank you for your testimony. Grateful for the good work you do every day. And you report that patients remain confused about whether their medical bills are covered or not, and if they are, how much cost sharing they are responsible for. Why do you think patients are still receiving bills they should be protected from, and how would you suggest that patients help navigate this process to protect them from illegal surprise billing practices?
Thank you for the question. Health plans, consumers are not always held harmless as they should be under the No Surprises Act. Consumers still receive surprise medical bills. And what we do at Community Health Advocates is help a consumer who doesn't know they have a surprise bill, but calls to say, I have a bill I can't afford, or why didn't my health insurance pay? And then we go through a complicated process to help them figure out whether or not it's a surprise bill and to make the plan hold them harmless, go through the appeals processes, or complain to the regulator.
Thank you, Mr. Chairman.
I recognize the chairman of the Health Subcommittee, Mr. Buchanan.
Thank you, Mr. Chairman. I want to thank all our witnesses for being here today. As a business guy for 30 years before I got here, I'm just looking at everybody talking about the backlog. It's outrageous, especially when you're talking about cuts. You send a bill in, you might not get paid for multiple years or whatever that time frame is. Obviously, it's just shocking. So I don't know, are there firms out there? Is there frivolous lawsuits? Is there hedge funds? What's driving, Mr. Beck? You mentioned the idea of 110,000 claims. I can't imagine that, but the other gentleman over here mentioned it'd be 10 years before you might get paid. Nobody can run a business like that, especially in the whole healthcare field where a lot of people feel like they're not getting paid fairly to begin with. Compound this, you're out of business for a lot of small firms, as we talked about earlier. But what's your thought on this? What's driving this massive amount of backlog?
Congressman, just as a brief note, there are 13 different IDREs, of which we are one. Although FHAS has received 81,300.
But out of your one, there's 130,000 claims you're managing?
We have received, since the inception of the program, 81,359.
And you're one of how many firms?
There are 13 firms overall.
So what are you talking about, a million, millions of claims?
So since the inception of the program, and the CMS has not released their latest statistics since March, but it is conceivable that by this point it is close to that. But for FHS, we don't have any backlog. The timeline to get a decision out by law is 30 business days. We're doing it in only 23 calendar days. And the reason for that simply is we have a large staff who's working around the clock to get these cases out. We have a sincere, humble understanding and responsibility to know that how our cases, the arbitrations we make, affect the entirety of the provider and the payer system as well as patients. We understand that we need to make these decisions. Ultimately, in any decision we make, there's somebody who is normally upset, somebody wins and somebody loses. But ultimately, what we suggest is that people continue to move forward with the process. We will continue to have no backlog. We will continue to make decisions. Program rules around it did ultimately create backlogs. As noted, the program has been on hold since August 3rd.
But the backlog that's been created, how long does it take to get paid under normal circumstances, ideally, are the ones that are in the dispute area?
When a decision is made, as noted by Ms. Thornton, the plan needs to make their payment within 30 calendar days. However, even before we get the case, most likely 2 to 3 months has already passed by before we even get the case. The parties going back and forth among payments, trying to negotiate it on their own. So conceivably, the process can take about possibly 5 to 6 months. And again, that's why we make our standard when we receive a case, it's 23 calendar days to get out, to get those payments moving along.
Thank you. Dr. Beyer, let me ask you, there was a point made on behalf of the organization you're with or work for or something. 52% of the payments are not made on time or not made at all. Is that what you said?
I don't recall that specific number, but if you're speaking to our experience with the IDR process, the overwhelming majority of the cases, the IDR process effectively been inaccessible for us for a number of different reasons I think everyone's already aware of. Out of the 400 plus submissions, I think 20 have gone through arbitration thus far. The rest have been unadjudicated, haven't been signed.
And how long does it take to go through arbitration in a case normally?
You know, From our experience, I think there's some statistics that say 90% of cases or 91% of cases still haven't been adjudicated after 6 months. I've seen some information along those lines. I don't have that information in front of me, but I can tell you this, the majority of cases that we have won, overwhelming majority of cases that we have won, we've received zero payment from.
Yeah, but the other side of that, the time, the energy of your executives or employees through that whole administrative process is a nightmare and very costly. And then you get paid and it's not half of what you think it should be. So it's challenging. Is there any other outside factors that are creating this environment in a negative way?
You know, I imagine there are. You know, the main issue is it's just inaccessible. And we've been put into this position because, again, we've been kicked out of network from payers that we were in network with for years. We don't want to access the IDR process, especially given what's going on right now. We have no choice. And unfortunately, despite that being our only recourse, it's a bit of a false recourse for us right now, because if we do enter that, you know, it takes forever to potentially be adjudicated. Number two, oftentimes, typically the fees associated, especially when they're $350 for the non-refundable fee, let alone the additional administrative fees that are part of this IDR process, far exceed typically our bills in the first place. So if we enter the process, pay the $350 non-administrative fee, and then win the case, and then not get paid on top of it.
Thank you. My time's up.
Excuse me.
Mr. Doggett is recognized.
Thank you very much. 8 years ago, I introduced the very first surprise billing legislation in the Congress. And I was inspired by stories like the one Ms. Spicer referred to. In my case, a Texas woman who did all the checking to be sure she was in network, and then some instrument was used unknown to her in the course of the surgery, and she got a huge bill for that instrument, which was out of network. Or the constituent in Austin who got a $4,000 bill for a colonoscopy out of network. It took another 5 years after the bill was first introduced, a blitz from private equity companies urging us to do nothing, and heavy lobbying before any legislation was passed out of this committee or became law. The battle largely became between healthcare providers and insurance companies, with some justified claims on each side and some abuses on each side that we produced this final piece of legislation. And it should come, I suppose, as no surprise today that whether the bill is adequately protecting consumers is not being fully explored. Ms. Thornton, you testified in the very first subcommittee hearing we had about surprise billing in Congress. And I note your testimony confirmed by other consumer protection groups that consumers are being protected from about 1 million surprise billings every month as a result of this legislation. But today's hearing fails to explore the loopholes referred to by Ms. Spicer and others of you, such as urgent care centers, ground ambulances, some of the problems that develop concerning pathology and lab tests, and other areas. And I think that's where the focus should be, is why aren't we providing more comprehensive protection to consumers? Consumers, of course, in a discussion like this are not the sole concern. This Congress has shown a consistent inability to address the problem of soaring healthcare costs. It gets talked about a lot. There's finger pointing trying to blame one party or the other for those soaring costs. But when it comes to really doing something about it, and that's at stake here, the Congress fails to act. On the other hand, the notion that a private practice of physicians can't get treated fairly is a legitimate concern. Ms. Thornton, if I understood your testimony, the way the system is now, with all the improvements that may be needed in the system, it is the healthcare provider, are you saying that prevails 71% of the time?
Yes, that's according to data released by CMS.
So really the question is whether or not there are enough changes that are necessary in the way this law is being implemented to increase it so that it's higher than 71%.
Yes, we'd certainly love to see a more balanced process. The chairman mentioned the advanced explanation of benefits earlier. We certainly think that that transparent process could be a potential game changer to make sure that consumers, when they're scheduling services, can make sure that their providers are in network.
One of my concerns is that so often the conflict is not between a private medical practice of a small group and a giant insurance company, but between private equity and a giant insurance company. I noticed that about a third of the complaints are coming from one Atlanta-based equity-backed private staffing company. Do you have any sense as to why that's happening?
Well, that's a really great question. I think we need to go have a little flashback to why you all passed this law to begin with. At that point in time, there were certain private equity-backed staffing firms that were really using the threat of surprise medical billing to extract really high relative to Medicare reimbursement rates from health insurance providers, right? And that is the reason that Congress really took bold action to pass the No Surprises Act. Unfortunately, what we are seeing, and the data released by CMS does bear this out, that we continue to see a really small subset of providers really taking advantage and using that arbitration process. You know, it's not the small mom and pop type of providers that are taking advantage of this. This is large, very well-established private equity-backed firms.
Well, I'm concerned about the testimony of all of our witnesses, particularly some of the comments Mr. Budzinski made about the cost this has, but it has to be a balance, not phony balance billing as occurred and produced surprise billing in the past. I think we can make some improvements, but the focus ought to be on the consumer first and foremost. Thank you very much.
I recognize Mr. Smith from Nebraska.
Thank you, Mr. Chairman. Thank you certainly to our panel here today for sharing your expertise and insight. It's I think we've got many great perspectives here to try to help us take what is obviously a bipartisan, I think, achievement previously, and look for ways to improve upon what the situation currently is. It's disturbing to hear various data points, and certainly delays, and time is money. We know that. And the disruption associated with lack of payment, I think, should concern all of us. So I hope that we can take away, from this timely hearing, some solutions. Ms. Spicer, thank you for your work with as a community health advocate. Have you observed any patterns that would be disproportionate, perhaps, in terms of underserved areas or rural areas impacted by the shortcomings that currently exist?
We have in our program, we have some of our agencies in the Community Health Advocates program. They serve communities in rural areas in upstate New York. And we have seen problems across insurers for 20 years or more around access to care in those rural communities. And so, yeah, there's still issues that are there and will potentially be worse if networks shrink. They're already very, very small in rural areas in New York.
And so the difficulty of navigating the whole process for those, from rural areas, for example, is there anything that stands out to you that we should be especially mindful of?
Just access to help. In rural areas, access to everything is a little bit less than in urban areas potentially, so access to help with them, for those patients to find in-network providers, understand what costs they may be facing if they're forced to go to out-of-network providers, and access other options like low-cost care and clinics.
Okay, thank you. Dr. Bleier, can you give us a little more detail about what you have observed as unique challenges, perhaps, that rural providers face when complying with the No Surprises regulations?
Sure. So our overall payer mix is probably about 15% in general self-pay, and probably about 30-ish% Medicaid, so about 42 to 45% self-pay and Medicaid, both of which, for self-pay, unfortunately, they're not able to essentially pay anything, and Medicaid certainly reimburses at a much lower rate than the cost of the care we're providing. And we have roughly another 25% that are Medicare as well, which is also relatively low. And then the rest are commercial. And for those rural communities that already have a lack of resources in the outpatient setting, oftentimes these patients can't get in to see their primary care physicians. They may not have a specialist available. In addition, they have limited resources to begin with. So they wait and wait and wait. And a common thing that we see is these patients present to our emergency departments with a true emergency, in extremis, things that could have been preventable to begin with. And when the emergency medicine providers there are also suffering under this law, the law related in the manner of the legislation itself, that puts undue pressure on those groups, because they can only spend what they bring in on resources. And all of that money for a group like ours that we receive in reimbursement goes directly back to pay our providers and our staff that helps our providers. So in a rural community, when they're already under-resourced, we are the true safety net of those communities. And if we don't, and we're not able to provide the staffing in those rural EDs, when there is a crisis, that rural community will suffer, unfortunately. And it's heartbreaking as a physician to have to see that. But unfortunately, those are the unintended consequences.
All right, thank you. I yield back.
Mr. Thompson is recognized.
Thank you, Mr. Chairman, and thank you to all the witnesses for being here today. As has been mentioned numerous times already this morning, we passed this bipartisan legislation to protect our constituents from surprise medical bills. It was needed. I heard in my district offices and my capital offices probably daily, and that's not an exaggeration, from constituents who had received surprise billing and were having difficulties with this. As Mr. Doggett pointed out correctly, that this has been something we've been working on for 5 years before we passed the original bill. And I think it's important to acknowledge that our goal of protecting our constituents was met by the bill that we passed for the most part. But there's still challenges, and I agree with all of the witnesses and my colleagues that we need to figure out how to address those and make this an even better bipartisan solution. I'd like to ask about something I've heard from providers in my district, and that is that insurers are often simply ignoring the timelines for dispute resolution that was required by the law that we passed. And I think it's important to be clear that when we pass a law requiring payers and providers to go through a dispute resolution process, we intend for the relevant parties to participate in that process, not ignore it. Mr. Badinsky, you alluded to this in your testimony. Could you talk a little more broadly about the issue of payers unwilling to participate promptly in the process and how we as Congress could address that?
Thank you, Representative. It is a fact that timelines are not being adhered to by many parties. Providers are required to hit certain timelines to submit a determination request on a timely basis, and the penalty for missing a deadline for filing a determination is that determination request is dead for a provider. End of story. It's just gone. With respect to other parties involved in missing corresponding deadlines, that is not the case. And we'd be glad to provide further detailed evidence to you and your staff about where insurance companies and IDR entities have missed their timing, and still there is no result except an increase in inventory of delayed results that we're seeing in our health system.
Yeah, I'd like to see those data, if you could provide those, please.
We certainly will, sir.
Thank you. Ms. Spicer, you mentioned that insurance plans, at least in some instances, fail to automatically hold patients harmless for surprise bills. This is a fundamental problem. Holding patients harmless was the central point of the law that we passed and what all of us wanted to accomplish for our constituents.
What are some things that Congress can do to make sure plans know their obligations and meet those obligations under the No Surprises Act?
Thank you for your question. Yes, I have seen at Community Health Advocates on our helpline, consumers call with classic surprise bills that should be covered under the NSA. However, plans are not holding consumers harmless for those surprise bills. I would say that, there's health plans get coding and information on when a claim is submitted and should know that claims fit certain criteria and should be paying and negotiating with a provider in a way that holds the consumers harmless. This is done for even before the NSA, before New York surprise billing law in certain commercial health insurance plans called HMOs. That's what our surprise billing law in New York was modeled after, the protections that some protections HMOs consumers had already in place. So I think it should be kind of built into the claim system that the health plans can see what kind of claim and whether the claim would be a surprise bill and hold the consumer harmless for that claim.
Thank you. Yield back.
Mr. Kelly, you're recognized.
Thank you, Chairman, and thank you all for coming. So Mr. Buchanan and I are in the same business. We sell cars. The biggest customer we have in our service department, by the way, is the manufacturers. And we have the health care plan for the owner of the vehicle is their warranty. That's also the biggest revenue stream we have coming into the store. I can't imagine how you're running a business with the accounts payable never being paid. I've been in a personal situation where, and my wife will get mad at me for this, but I think it's important people understand this. We have a son who's a heroin addict, and he was in a halfway house in LA. He passed out on a sidewalk. Somebody called an ambulance. They took him to a hospital. I kept wondering why he wasn't answering his phone, and the reason why is he was in the hospital. So eventually, within 4 days to get out of the hospital, we had a chance to talk to him. And the reason I bring this up is because unless you've gone through it, you can't understand it. About 2 months later, we got a bill for $260,000. And my wife went absolutely, she says, oh my God, what are we going to do? I said, I'll tell you what I'm going to do. I'm not paying any attention to it at all. And it went away. I don't know what happened, and I don't know how you all absorb the accounts receivable that you have on your books that you never receive. It's absolutely incredible. This invasive species, being government, has got its hands into everything and made it so difficult for normal businesses to absolutely survive. I don't get it. I've been in business all my life, and the two most important dates of every month of me are the 6th and the 21st, and people say, is that an anniversary time? I said, no, that's payday. But we don't always see the revenue stream, so I can't understand. How can you possibly run the businesses you're in when your biggest customer doesn't pay the bill? And we talk about wonderful things that we're going to do legislatively, and that's all good. We can put it out there, but following the model is incredible. I would never take advice, by the way, from a company that was $33 trillion in debt. I would say there's probably not one of the plans I want to follow, but you have are so complicated. So you can't fix something with nothing. Now, Dr. Bleier, are you by any way interested to a young man that grew up in Wisconsin, then went to Pittsburgh? His name's Rocky Bleier. Is that somebody that...
My grandfather would tell me that I was fourth cousins.
Okay.
I don't know if I can't verify that.
Well, you know, the fact that you take time out of your life to come here today and try to help us understand what we don't understand and how the policies that were well-intended are actually not working, and that your business model is a business model that is totally unsustainable. I don't know how rural hospitals exist anymore. It's incredible when you don't have the people on the shelf that could service the patients that come in. And I think what they mostly rely on now is just emergency care because they don't have people that can handle more complicated issues. And there's just no people out there to do that anymore. If you could just give me a hand, just a little, what is it that we could actually do? It's nice that you came in here. It's nice that we're talking back and forth, but I don't know. I still If I was at the dealership, the first thing I look at every day is our accounts receivable. And the ones, if they were over 90 days, write them off. They're not coming back. They're not coming back to get anything from me, and they're never going to see them again. But they walked away. You're on the hook for what it is they have done. We have to pay the mechanic that did the work, and we have to pay the parts department for the parts we put on. So what is it that you can do? Because I'll tell you what, it is incredible today, the accounts receivable that we're all trying to balance out. You are graced with the fact that the government now is involved in it. So that's an eye roller. But what could we do? It's just simply tell us what we could do to help you.
I would say some different things. Number one, we are the safety net for the healthcare community, for the healthcare system across the country, and we take care of patients under the most adverse circumstances when they're most vulnerable, as I'm sorry to hear about your experience, from your family. But I think that, some type of reimbursement for unfunded care would go a long way to providers who take care of those patients. And I would say, with regards to the NSA, some enforcement that insurers are calculating the QPA correctly, and enforcement in teeth that they abide by the arbitrator's decision and submit payments to providers or hospitals when the ruling goes in that way. Because of right now, there's just no enforcement, even though it's a great bipartisan piece of legislation, and that's my concern.
My time's running out, but I got to tell you, I don't know how you do it. I don't know how you write off and your accounts receivable of things you never receive. It becomes a taxable event for those that don't pay it, I think, but I don't think we enforce that. But I want to thank you for everything you do. It is incredibly important what you do, and the fact that you face an unbelievable, complicated business model. I don't know how you do it. God bless you. Hey, thanks for coming in today.
Mr. Blumenauer is recognized.
Thank you, Mr. Chairman. And I must say, Mr. Kelly, I appreciate your bringing it back on a personal direct. I know that's not easy, but it helps give the committee a sense that there are human consequences.
So, Mr. Blumenauer, you and I understand each other, and Ranking Member Neal. The things that we go through personally, I think we sit up here and somehow we don't connect, and I say to people, yeah, we do connect with you because we go through the same thing. I wish we were the only family that had that problem. It is incredible, and especially mothers, they can't walk away from it. They just can't, and it's really, all you do is just keep supporting them, and I think that's what we do. So I appreciate your comments, and my wife is going to kill me for talking about this today, but I got to tell you, until you actually go through it, you know how when you're little and you're growing up and your parents will tell you when the stove, don't touch the stove, it's hot. Everybody has to touch the stove. You don't know it until you get burnt. So it's good being with you, sir.
Well, I appreciate the reminder that in the final analysis, we're talking about people, and there are areas, regardless of our differences, that there are ways that we can come together. This legislation was actually an example of coming together. It has largely solved the problems, but we have heard today eloquently from witnesses that it hasn't gone far enough. There are things that are head-scratching. And I appreciate the chair and ranking member bringing this back before us, because we ought to have a commitment to follow through on a good start. We ought to do better, and I would think that there's a chance to do that. And the witnesses have helped give me a better sense of the shortfall. Mr. Blyer, I mean, you explained that the majority of the cases you won, zero payment, and that the bills are often more than they are worth. Can you talk for a moment about that dynamic and what you think we could do to help you move that forward?
Yeah, I appreciate that. I think enforcement of the legislation would go a long way. I think that a lot of groups like ours are forced to enter the IDR process. Yes. We have no choice. We've been kicked out of network from contracts that have been standing for up to or more than a decade with unchanged reimbursement rates. And because we are kicked out of network, we are forced to go through the IDR process. Right now, we have no leverage with the health insurance companies. We want to go back into network, and initially, we received For example, a 40% reduction, we, a few months ago, went back to one insurer, said, hey, can we go back in network? We had a 60% reduction. So until there's enforcement, and I think that the insurers are forced to pay consistently with the arbitration ruling, we'll be at a disadvantage, and this process will continue.
And I would appreciate if you have some thoughts about ways that we can implement that. It makes sense. I don't want to do it now. My time's almost up, and I have another question. But your thoughts and observations about what would make a difference for practices like yours would be very useful. Mr. Budinsky, you talked about large insurers who refuse to negotiate. Could you elaborate on what you think we can do to try and remedy that, to make sure that people are playing by the rules, operating in good faith, and doing the roles that have been assigned to them?
Thank you, Representative. I think the number one framework of this phenomenon is that the unintended consequences of how the act's been implemented is large insurers no longer need to have emergency departments in network in the counties where they sell insurance. They are selling insurance in counties where they don't have any emergency departments in network. How is that possible? The reason is they don't have a need to have an in-network emergency department. They don't have to negotiate with a hospital or a health system or a physician group because they can use the No Surprises Act process as it's currently being implemented to pay in-network rates for out-of-network care. And that has never been the case in the last 30. I've been in the healthcare finance business for over 40 years. That has never been the case. Out-of-network care, because of its uniqueness, is always reimbursed historically at greater than in-network rates, because with in-network rates and discounts, there's always an expectation of more volume and therefore more discount. With out-of-network care, all elective care is steered away from you, and now you're left with only emergency care. So I think that the solution to this is require that under the Act, that the initial payment being made by insurance companies meets a minimum level that's consistent with historical out-of-network payment for emergency services.
Thank you, sir.
Mr. Schweikert is recognized.
Thank you, Mr. Chairman. And Ranking Member Neal and the Chairman, and many of us have been around from the beginning of the debate and discussion on this. So I want to walk through and make sure I'm listening, sometimes something I don't do well. The discussion is almost, it has two ends on this. Some of it's the actual administering of the law, of the rules as it is, how long it's taking, the bureaucrats, the time. And some are, maybe some of the game playing has happened from the administration's rule drafting and those things, of what we thought we were getting compared to how it's been drafted. Setting that aside, and Mr. Bobek, forgive the nature of the question, but I'm going to beg of you, be as brutally honest with me as you can. If the rule sets, saying, okay, here's the rules, that this is an out-of-network, this is, what the arbitration, why can't you and I just automate that? Why can't we just write computer code that says, here's the market area, here's what it is, and here's it, and it's spit out? Tell me where and it's not AI, that would actually technically be more an algorithm with constant updating of the data. Why can't I completely automate this?
Congressman, thank you for the question. AI relies upon one thing to do those algorithms, which is set data. The data is not set in this particular case. Our firm, since its inception, its founders told us is a very important piece of technology that we have to rely upon that's been helpful for us through this process, and it's called the telephone. We have to continually talk with the parties to make sure that they understand what are they dealing with. When parties want to submit a claim, many times the provider doesn't even know which health plan that they are trying to dispute. They're not even quite sure who they have to tell that they would like to dispute. They're not quite sure the evidence they have to provide. And the same thing on the payer perspective as well.
But Mr. Bobek, in many ways and I want to make sure we're not crossing each other, but that's actually where automating it, check, put this in, check this, the hyper-standardization you could take away my friend from Georgia's time problem and filing problem, and collapse the actually some of the cost, but also the speed. Why can't we ultimately, because picking up the phone, it's friendly, and you and I know how inaccurate a conversation can be.
Thank you. Ultimately, since the program's been involved for 1 year, parties are still getting to understand the process. But I will say this, where parties provide the right information, you are exactly right, the process goes much faster. Process and decisions can be made in less than 2 weeks, and that is frequently happening right now. CMS, I cannot speak for them, but I do know that through the portal that they have created, they have continually made improvements, and they have more improvements to make, which will automate many parts of the process. They did not put that out in the first model. The first model was simply to get it off the ground, but you are exactly right that those are future improvements that can be made, they will be made, and they will make the process much more seamless, and I will say very cost-effective for everybody.
Thank you, Mr. Bobeck. Mr. Chairman, maybe as we start to have our discussions, our bipartisan discussions on the side, the finding out where we do not believe the rule sets fit our vision, okay, fine, that may require us to push some letters or do some statutory. But what we should also maybe have an interesting discussion is what would make this as seamless as possible? That if there's going to be a dispute, it moves fast, quick, efficiently, inexpensively. And that may be making it very clear that technology can be the arbitrator. And with that, I yield back.
Mr. Pascrell is recognized.
Thank the witnesses. Surprise medical bills were once on the top of the list of expenses Americans really do worry about. Whether it's an emergency or an inpatient case, inpatient care, Americans must be protected. We came to that conclusion. Despite the tired promises, insured patients keep facing lawsuits, wage garnishments for medical debt. That's pretty gross. In fact, it may be outrageous, but it's unacceptable. So in 2020, committee Democrats enacted the bipartisan No Surprises Act to protect patients. Our law, I believe, was carefully crafted to take patients out of payment disputes. Remember back in that debate, the administration must implement the law as Congress intended. No ifs, ands, or buts. Our law was designed not to jeopardize patients and tilt the scales for industry. Regulations that avoid these goals are not going to help the patients. I don't think we are of like mind about that issue. Patients need transparency provisions fully implemented, and the law must be followed. So, Dr. Bleier, yes or no? Do health plans that fail to follow binding dispute resolution decisions that collect interest on money owed to physicians threaten physicians' financial stability? Yes or no?
Yes.
Dr. Bleier, yes or no? Should there be a financial penalty on an entity that fails to pay within the 30-day required time period?
Yes.
So quickly explain how health insurers issuing timely payments can help ensure patients retain access to physicians. Give me a quick explanation, if you will.
If physician groups and emergency medicine groups are reimbursed promptly, it allows them to have the resources needed to take care of patients in any environment, including rural environments, with less advantageous payer mixes, where perhaps they have a disproportionate number of Medicaid and self-pay patients. And by increasing those resources, I think that patients will get much better care.
Dr. Bleier, in August of this year, the courts stepped in to resolve guidance disputes for the independent dispute resolution. That could have increased administrative fees by 600%. Remember that. What is the negative impact of higher administration fees, Dr. Bleier?
The higher administrative fees, both the non-refundable and potentially refundable if you win, oftentimes greatly or significantly outsize the professional side or provider side bill. So
And therefore,
it precludes us from entering the process. And even if we win a dispute, we oftentimes lose because of the non-refundable portion of those fees.
does that make sense, Dr. Bleier?
I hope so.
Oh.
Yeah. Not always, but yeah.
And what's the impact of the higher patient fee access? What's the impact?
From a patient perspective?
Yeah.
So again, an independent group like ours, we have no private equity backing. We have zero debt. If reimbursement levels fall, and that can be through higher expenses associated with fees, then we have less resources to allocate towards what we really want to allocate our resources towards, our providers taking care of patients at the bedside. If we have less reimbursement coming in, we have less to staff and provide those resources.
How deeply is private equity involved in this?
It's hard for me to say. In our experience, we've never had any equity backing, so I really can't speak to that. We've been an independent group since 1992, so it's hard for me to say. Sorry.
Mr. Chairman, thank you for your time.
Thank you. Dr. Winstrup is recognized.
Thank you, Mr. Chairman. I appreciate all the input today from all the people on the panel and our members, and I want to thank Chairman Smith and Ranking Member Neal for having this hearing today. You know, when we put together the No Surprises Act, we worked with all of the doctors in Congress, Republican and Democrat, who I might say, if I can, the real protectors of patients in this world. And we considered patients first. We wanted to alleviate their anxiety by taking them out of the equation. I can tell you firsthand, there are some times when patients worry more about their bill than they do their illness. And we wanted to take that anxiety away. It's very important in the healing process. We thought about providers who just want to help patients but get reasonably paid for the work that they do and go on to see the next patient and help the next one and not spend a lot of time in arbitration and other areas. We thought about insurers. We wanted them to be able to pay a reasonable fee so that they can sustain their ability to insure those that they claim to protect, and that they will have providers, especially quality providers. We created a system that we believed would lead doctors to want to be in network and lead insurers to strive to have doctors in network and provide their patients with a quality panel and a reimbursement to providers that was respectful of the care that they rendered to the patients and to fulfill the promises made to the patients that they insure. You know, I can remember once I had a patient in tears in my office because she said, "I chose this plan because they listed you as a member." I said, "We haven't been in it in 3 years." That was some of the motivation right there for getting some of the changes made into this bill. That insurance companies could no longer give false advertising, basically, saying this is our product when it wasn't. That's what was happening. And we go through the process where a patient wants to know what their elective procedure is going to cost. We ask the insurance company, and they say, you have to perform the procedure and then bill it first. Oh, that's a real doozy for the patient that you claim to protect. You know, Dr. Brzezinski, you talked about out-of-network. Out-of-network always paid more. Patients always had to pay more out-of-network. They knew that, and they made that choice willingly. Those were the rules. You summed that up very well. And when, you know, here, when it looked like one committee was going to go ahead and have a benchmark, well, what had happened? We have the documents. Insurance companies immediately started sending notices out to doctors saying, we're going to reduce your fees, because this was going to work for them. Providers got the letters. We've got them. Dr. Bleier, you talked about what's happening now because of this. We're going to cut your fees. We're going to cut your fees. I mean, in situations like we have now, doctors quit taking call. I was in a large orthopedic group. You just say, we can't afford it anymore, because especially if they're out of network. We know what's going on. And without doctors, what's your product? So why are we going towards this? And at a time when HHS and other agencies, they get a cost of living increase, doctors are getting paid less under Medicare. And all this just makes it worse and worse and worse. And these are the ones that actually provide the care. I asked the rhetorical question, who would have the motives to change the clear intent of the law that we have discussed today? And why? And what were the arguments that were made? Who had the influence for these changes? It certainly wasn't Congress, because we made it very clear. I will submit for the record the 3 letters that we sent to HHS before the rulemaking process, spelling out the clear intent. We had a Zoom call with HHS Labor and Treasury, spelling out the intent before the rulemaking process. Bipartisan, we did this. And I might add that until Dr. Ruiz, who was on the call, emergency physician, until he spoke up, they wouldn't even show their faces on the Zoom call. And he said, would you mind showing us who you are? And we asked who made the decision. Nobody could answer that. Who really made the decision? Who made the argument? I mean, Ms. Thornton, I would imagine, I would guess that in the comment and rulemaking process that your organization and others affiliated with you probably made comments to HHS and others, right? Well, my only question to you is, would you mind sharing all the communications that you had with HHS, Labor and Treasury concerning this topic? Would you mind sharing those with Congress?
Yes, we're happy to have conversations with you, office, about that.
Well, I'd like to see your actual communications that you sent. I appreciate that. Thank you.
Thank you. Mr. Davis is recognized.
Thank you, Mr. Chairman, and thanks to all of the witnesses for a very serious discussion. You know, when we passed the No Surprises Act into law, it was designed to protect patients from predatory surprise medical billing, establish a third-party mediation process called independent dispute resolution to determine the amount of money doctors will receive for their health care services to patients from insurance companies. The problem is often profits versus greed. The law uses an IDR process as a framework where payers and providers negotiate and submit offers of what they believe is a responsible, reasonable payment for medical services, and the arbiter considers the qualifying payment amount, or OPA, to be paid to doctors. The arbiter by law is to consider a range of factors, including a measure of median in-network contracted rates for the health plan, the history of in-network contracting with plan and provider, the complexity of the case, and the education and skill of the physician. All of these factors are supposed to produce a fair compensation for the doctor. Instead, the insurance companies are the ones that produce the sole data used in this process without the consideration of other pertinent factors that tend to deflate the rates to in-network providers and narrow the number of doctors in-network. We understand that the impact of these policies is causing ripple effects through the health insurance market and impacting physicians' ability to negotiate fair contracts with insurers to be in-network, because all contracts are now being negotiated under the OPA ceiling, as plans know that this amount is the most they will pay, whether the physician is in or out of their network. Dr. Bleier, how important is it that IDR entities are permitted the independence to look at all the allowable information submitted by a party to support their offer and then make a determination of payment?
I think it's extremely important, and that's why I think my understanding is all EMTALA-related physician specialty groups and physicians supported the Texas Medical Association's lawsuit against HHS to make sure that all of those factors were considered and undue emphasis wasn't solely placed on the QPA when making those determinations.
And then let me ask you, what is the impact of these policies on the stability of physician practices and in turn patient access to physician services?
Unfortunately, the way the system is currently operating, I think it is going to become debilitating if it goes on too long. I think certainly I can speak for my group as an independent group that wants to go out into rural communities and potentially provide our services in those emergency departments. We already have 4 in those rural communities. We are actually looking to potentially expand. I think it's debilitating. I think we simply will, our reimbursement and revenue will be cut to such an extent we will have no recourse if this continues much longer but to cut expenses. And our expenses are provider staffing hours, our providers. So unfortunately, I think it will have a harmful effect on our patients.
And finally, I understand that patient wait time in emergency rooms are getting longer. Does this impact the service?
Unfortunately, yes, there is an ongoing boarding crisis across the country right now due to a number of, I believe, workforce issues is my understanding, but it absolutely creates a difficult work environment for my fellow colleagues in the emergency department, and more importantly, a very difficult situation, I think, for our patients. But as always, as emergency physicians, we do the best we can, and we're resourceful with the limited resources that we do have. So we still try to provide excellent care to every patient, no matter what the conditions are.
Thank you very much, and I yield back, Mr. Chairman.
Thank you. I now recognize the gentleman from Illinois, Mr. LaHood.
Thank you, Chairman. I want to thank our witnesses for your valuable testimony here today. And I am pleased that this committee put this timely and important hearing together today. Understanding the cost of healthcare services in advance empowers patients to make informed decisions for their families, better manage their healthcare finances, and advocate for fair and reasonable health care costs. Like many of my colleagues, the cost of health care is one of the top issues that I hear about from my constituents back home in central and northwestern Illinois. Enacted in 2020 with strong bipartisan support in Congress, the No Surprises Act, which we've heard about today, has largely been a success in providing certainty for patients when receiving care. Because of this committee's bipartisan work and leadership, today, patients in every state across the country are better protected from most surprise medical bills. While this committee made great strides towards protecting patients from costly and unnecessary out-of-network costs, we have unfortunately seen agency officials bypass congressional intent on surprise medical billing protections, which ultimately harms patients' access to care. In rural counties, in my district, access and choice for healthcare services can be a significant challenge. Flawed implementation of the No Surprises Act has reduced patient access to care, which in particularly has affected rural and underserved areas. As I visit with my rural healthcare providers, they continually stress the fact that IDR process has been virtually inaccessible for small practices given their limited capital availability compared to many large and urban practices. Hospitals and healthcare facilities should be focused on delivering needed care and services, not worrying if IDR billing process costs outweigh any benefits for patients and providers. The No Surprises Act was carefully drafted so as to not tip the scales in favor of one party over the other. And my hope is this committee and the executive branch can work to remedy this imbalance. My question for Mr. Bobeck and Mrs. Thornton, in your testimonies, you both mentioned the need to look at the IDR process and how reforms in this space would better allow dispute filing and compliance with the No Surprises Act. Can you both expand on what could be done by CMS to improve the functionality of IDR process to streamline and to reduce burdens on the parties? Mr. Bobeck.
Congressman, thank you very much for the question. The first thing that can ultimately be done is regarding the batching process. As many of the Congress members know, batching is a process by which different disputes can be put together. Right now, the process does not follow normally how providers and payers bill each other. They usually bill in an episode of care. Somebody comes in, there's various codes associated with giving that care, and then they will be paid upon that. That's not how the batching process works right now. CMS is currently undergoing the batching process and changing those rules. Making those rules more in tune with how people bill would be a very good step in the right direction. Additionally, one of the biggest things that can be done is ultimately the portal itself. With more implementation of the portal, making more fields more clearly defined, parties can provide better information, and the more information and the better information they will provide, you will get a more streamlined process that will have decisions happening at a much more rapid rate. For our perspective, we have run various algorithms on our own end, and we can see very clearly that the better the data that's put into the system, the better the outcomes that will come out. Thank you.
Thank you. Ms. Thornton, do you have anything to add on that?
I 100% agree with everything that he just said. I think technology can really help streamline this process.
Thank you. Those are all my questions. Thank you, Madam Chair.
Thank you. I now recognize the lady from California, Ms. Sanchez.
Gentlelady, please.
Sorry, gentlelady.
Thank you, Ms. Chairman. I appreciate the opportunity to have this much-needed discussion on the historic bipartisan progress that we made under the leadership of Mr. Neal and Mr. Brady in passing the No Surprises Act back in 2020. And I'm incredibly proud of the work that we did to help patients struggling with unexpected out-of-pocket costs. Since then, Democrats have worked tirelessly to narrow the coverage gap for Americans. We passed the Inflation Reduction Act and increased ACA subsidies to decrease out-of-pocket costs for lower and middle-income working families. And as a result, we now see our nation has the lowest uninsured rate that we've had to date. And while the No Surprises Act is largely accomplishing its goal in protecting patients and consumers from surprise medical bills, many Americans are still saddled with high costs and, sadly, very confusing provider networks. For those who are struggling with high costs, this also means, unfortunately, that they must take on medical debt. 1 in 10 residents in Los Angeles County, including many of my constituents, are burdened with medical debt. And medical debt is one of the largest sources of debt in collections, more than credit card debt, more than utilities and car loans combined. And it's not surprising that Latino, Black, and Native American residents are disproportionately burdened by medical debt. And many of these folks are insured. It's not that they're not insured, they are insured. So these networks still need to deliver on the promises of the No Surprises Act. We still have more work to do. Now, Ms. Spicer, you mentioned that health insurance plans and providers do not automatically hold patients harmless when there are billing disputes. How long on average does it take for you or one of your employees to help consumers resolve a billing dispute?
Thank you for your question. It depends on the case. It depends on the capabilities of the consumer. Sometimes if you're going through cancer treatment, you can't call me back for a month. So I don't know what your notice says and how it relates to your bill and your EOB, and I can't really help you until you're well enough to communicate with me. So, and then other cases we can tell from a quick call and an intake script whether or not a bill is a surprise bill and what to do about it. So it really just depends on the case, but I would say on average anywhere from 6 weeks to 6 months.
6 weeks to 6 months, and that's with the help of someone who's very familiar with the insurance system. Would it be fair to say that consumer assistance programs are still underutilized by many Americans?
Yeah, I think that's fair to say. We get at New York's Health Insurance Consumer Assistance Program, we get 8,000 to 10,000 calls a year. We are on the explanation of benefits and the adverse determinations of commercially insured consumers, and recently last year added to the adverse determinations of Medicaid managed care consumers. So we have kind of a broader audience. Those are state regulations that require that notification to consumers. Otherwise, they wouldn't know that we existed.
And so what happens to the families and patients who don't know to seek out the help that a consumer assistance program provides?
They would pay a bill, or they would not be able to pay a bill and go into debt. I got a client on our helpline last week who received a bill for an out-of-network lab, but not a corresponding EOB. And if you don't have an EOB to explain that your bill was denied as out-of-network, but could be a surprise bill and follow that process, and you're not held harmless by the plan, and you're not savvy enough to know, you would pay.
Thank you. So oftentimes the people who are least in a position to pay end up paying. We've also seen provider networks grow narrower over the past few years. Mr. Budzinski, have you seen the provider network in your community change over the last few years?
Yes, Representative. We do see, particularly with the advent of the health insurance exchanges, major insurance companies in the country have decided that narrow networks are an appropriate structure for health insurance exchanges, and many of the major insurance companies in this country operate narrow networks in the service areas we serve.
Thank you. And Ms. Thornton, how do narrow provider networks impact the likelihood of a patient receiving a surprise bill?
Thank you for the question. I do think it's really important to talk about affordability. We all benefit when people can afford their health insurance coverage, and to do that, our plans need to provide, high-quality networks of providers where they can go and get care in a time of need. To directly answer your question, all of our plans provide provider directories that allow consumers to search, and thankfully, the No Surprises Act included new provisions, new consumer protections, that in the case that someone receives inaccurate information, they're held harmless from that. So that was a really important part of the No Surprises Act.
Thank you. I want to thank all of our witnesses for their testimony today, and I yield back.
The gentlelady's time has expired. I now recognize the gentleman from Georgia, Dr. Ferguson. Whoops. Sorry, Mr. Estes from Kansas.
Well, thank you, Madam Chair. And I want to thank you, all the witnesses, for joining us today on this very important topic.
Mark those off.
It wasn't too long ago that the committee passed meaningful bipartisan legislation to address a very real problem in the country around surprise medical billing. I'm sure all of us here have constituents who've been impacted by surprise medical bills. Erin in my district has told me about a nightmare she faced after her husband was in the emergency room in Wichita. They have insurance, thought they were doing the right thing by going to an in-network hospital, only to find out that one of the doctors who saw her husband in the emergency situation was out of network, causing a massive surprise medical bill. This is happening all too often in hospital rooms and medical facilities across the country, and Republicans and Democrats came together to stop it. The No Surprises Act was designed to remove patients from the middle of the surprise billing, empowering patients with upfront information for scheduled procedures, protect patients when emergency services were provided, and create a fair mediation process for providers and insurers. This bill was the type of common sense legislation that folks like Erin and her husband needed. An emergency room visit or scheduled procedure is stressful enough, but it can be even more challenging if it's followed by an unexpected medical bill from an out-of-network provider.
But today's hearing is a reminder why Americans are so frustrated with Washington. The unelected bureaucrats at CMS have failed the American people by not complying with the language in the bill we passed and instead creating a dispute resolution process that doesn't follow the spirit or congressional intent of the law. Even though elected lawmakers passed the Bipartisan No Surprises Act in 2020, the Kansans I represent continue to suffer because unelected D.C. pencil pushers are more concerned with keeping the status quo than helping patients. The failure in the D.C. swamp has led to fewer medical choices, longer wait times, and higher costs for patients, while at the same time has failed to deliver the transparency this body sought to provide for those seeking medical care. Today, we're calling on CMS, that's entrenched in putting Washington first, to stop slow-walking the implementation process and put patients first. Mr. Baczynski, I've heard from many providers in my state about the incredible wait times for not only the independent dispute resolution, the IDR process, but also for receiving payment once the IDR process has been concluded. Can you please tell me how many of these IDRs you've gone through and how many that have been paid for successfully?
Yes, thank you, Representative. Of our 8,000 requests for determination at Wellstar, 588 have been resolved. 288, I believe, are in our favor, and unbelievably, only 1/3 of those determinations in our favor have been paid by insurance companies. And the deficiency is with some of the largest insurance companies in this country.
If that process or that approach continues without some change, what's that mean for your business and more importantly, for the patients that you serve?
As mentioned earlier, accounts receivable that are never paid will impact our operations in the long run. We are hopeful that there'll be enforcement of the timelines to remit payments to providers who have been successful in getting favorable determinations from the IDREs.
Oh, thank you. And Mr. Boback, I didn't really have a question for you, but I did want to say thank you for raising the comment about the IDR website being closed, that you can't add any more IDRs. I mean, that's one of the things that we've identified by law, this process that should be helping people, and we need to make sure that it's highlighted that it's not being done. So thank you for bringing that up as part of this hearing. I just want to say, you know, the No Surprises Act explicitly required that we have an independent dispute resolution process that should be concluded in a timely manner, and payments should be paid no later than 30 days after the final decision. These considerable wait times must be addressed to ensure that our providers, especially those in rural areas, can keep caring for the patients that need them most. That's really what we want to focus on, is how do we make sure we provide the right care for the right patients, which I think is what all of you are focused on as well. So thank you, and I yield back.
Thank you, Mr. Estes. I now recognize the gentleman from New York, Mr. Higgins.
Thank you, Madam Chair. Surprise billing is a weapon in a decades-long war between players in the healthcare industry over who gets to keep the fortunes generated each year from patients. What's at stake here? According to the American Medical Association, healthcare spending in the United States in 2021 was $4.3 trillion. $4.3 trillion, or more than 18% of the U.S. economy. You know, 30, 40 years ago, most healthcare providers were not-for-profits. Businesses paid premiums. Patients typically were confronted with pretty modest co-pays and deductions. Those days are over. Healthcare has become big, big business. So hospitals, doctors, insurers are now in competition for the healthcare dollar. And then we have found even more egregious players in all of this, called private equity firms. The Kaiser Family Foundation, an article called Sick Profits, are investigating private equity's takeover of healthcare across cities and specialties that are highly profitable. Private equity spent nearly $1 trillion into nearly 8,000 healthcare transactions in the past decade alone. Private equities are not healthcare professionals, they're moneymakers. In fact, according to Forbes, to doctors, private equity firms offer an alternative value proposition promising to ease physician dissatisfaction with insurance hassles. In exchange, physicians agree to relinquish significant control of their practice to non-healthcare professionals. Ms. Spicer, you have some thoughts about patient protections in this area, but it seems to me that what is occurring here is big money's takeover of healthcare, compromising the best interest economically and in terms of healthcare of the patient.
Thank you for your question. Yeah, many times consumers are left with the balanced bill, and they're left holding the bag. All of these transactions make it more expensive in the end for consumers.
In the surprise medical billing legislation, it really is ineffective in addressing this issue. Would you agree?
I wouldn't say that all of the surprise billing legislation is ineffective in addressing the issue. I would say that if all the different provisions of the No Surprises Act were implemented, if price, the transparency provisions move forward, patients would be able to make more informed decisions regarding the care that they are getting, and thereby avoid debt. I think that the arbitration, the piece about arbitration and the fees, depending upon the rate that's set, it passes additional fees on to consumers. But I believe that if the original intent of the law is followed, that debt would not be passed on to consumers.
Yet it's undeniable that a for-profit or private equity that's taken over a medical practice, I mean, what is their objective? And what is the leadership's objective? It's to reduce expenses and to amplify profits. The only way that you do that is to jack up copays, jack up deductibles, and then when someone goes to use the insurance they've already paid too much for, there's very little underlying insurance. And I'm just concerned that federal legislation can't stop the trend that's begun in healthcare, and that is it's a $4.3 trillion industry annually in America, 13,000 per capita in America, and the profit motive is so strong that I'm concerned that legislation, while appearing to be helpful in the margins, is not addressing the fundamental problem. With that, I'll yield back.
Thank you, Mr. Higgins. I now recognize myself for 5 minutes. I'd like to thank Mrs. Chu for sitting in here for the ranking member, and I would like to thank all of you for being here today, taking your time to discuss with us such an important issue. Being from southern West Virginia, which is a very rural district, my top priority is making sure that my constituents have the best access they can to quality health care. In 2020, I was absolutely thrilled that the House passed the No Surprises Act to help patients all across the nation to deal with their medical bills, especially in rural areas, because many patients don't have much of a choice about where they receive their care, and this policy was a huge win for patient-centered health care. So you can imagine my surprise when I learned just how wrong the implementation of this bill has become. One concern I have about the No Surprises Act implementation is that Congress was very clear that ground ambulance services were not included in the NSA. However, I understand that some insurers are telling customers that ground ambulance services are subject to NSA. I would like to note that the failure of CMS to issue a clarification is creating real problems. Rural ground ambulance services are particularly harmed because they are often small companies or businesses with very limited resources, and many are struggling just to keep their doors open. Reports that some insurers are trying to force these rural providers to use the time-consuming and expensive IDR process when they aren't even subject to it, nor do they have established qualified payment amount. This is concerning to me, and I am dismayed that CMS hasn't issued the written clarification that would solve this confusion, and I hope that this is an issue that we will continue to keep an eye upon. Dr. Bleier, I would like to thank you for your hard working providing emergency medical care to rural patients. In rural areas where access to care is so often limited, it's important that patients who are seeking medical treatment, that they can do it without the fear of a surprise medical bill. One issue that we hear about time and time again is the lack of staffing available in our healthcare workforce. In rural areas, it's becoming harder and harder to find physicians that are willing to practice where their reimbursement rates are so much lower. This is due to the coverage mix of their patients. Can you speak further about how compliance with the NSA, as implemented by this administration thus far, has contributed to physician burnout in your workforce, and how this might influence physicians looking to start their careers in rural areas?
Yeah, I appreciate the question. I think physician burnout is very high among emergency physicians for a wide range of reasons, going back toward the COVID pandemic. And I believe it's the highest burnout right now out of any of the specialties based upon some of the recent polls that I've seen, unfortunately. It's a little bit of moral hazard right now. Our physicians always want to do right by their patients, and we try to do the best we can, and we're used to working under very adverse circumstances, but due to a wide variety of issues, including workforce-related issues, boarding, workplace violence, these are all issues that emergency medicine providers and other emergency medicine workers, nurses, et cetera, have to deal with in the emergency department. From the emergency medicine physician and nurse practitioner and PA perspective, when our resources for a group like ours are fully debilitated. Again, we were shocked when we found out when this law was passed, this bipartisan piece of legislation, we thought it was a great advancement. We did not think we would be affected by it because we had been in network with all the major payers in our region. But then we were kicked out of network. And it's like putting salt in a wound, quite frankly, for us, because not only are our providers working as hard as they can to do the best they can under very adverse circumstances, but when, on top of that, their reimbursement, their fair market reimbursement is cut, it makes it very damaging to them, I think, their psyche. I think it puts us in a very difficult position, and we want to do right by the patients. We want our resources not having to go to an IDR process. We want them to go towards our providers working in the emergency department to provide the very best care they can in these rural emergency departments or any emergency department we work at.
Thank you. I yield back my time. I now recognize Gentlewoman Del Bene from the state of Washington.
Thank you, Madam Chair. Thank you to all our witnesses for being with us today. I appreciate it. Like many of my colleagues on this committee, I was proud to pass the No Surprises Act into law to protect Americans from unfair surprise medical bills. Prior to this bipartisan legislation and similar state laws, including in Washington, regular people and families were frequently at risk of being hit with devastating surprise medical bills for emergency room visits and other procedures that were completely out of the patient's control. And while we've made great progress, there is definitely more to do, and in particular, there is a critical gap in our consumer protection framework, which is surprise bills for ground ambulances. According to Washington State's Office of the Insurance Commissioner, the vast majority of surprise billing complaints are for ground ambulance services, which were exempt from the No Surprises Act. So if someone with private insurance in my state has an emergency and calls 911 and gets driven by an ambulance to the hospital, they're not only on the hook for the copays and cost sharing if they haven't met their deductible, but may also have to pay a surprise bill of $500 on average. For non-emergency ground ambulance services, that surprise bill could go as high as $1,000. And it's not just a problem in my state. The Urban Institute's Health Policy Center has identified the lack of protection against ground ambulance surprise bills as a major issue for consumers across the country. And so, Ms. Spicer and Ms. Thornton, how has surprise billing for ground ambulances impacted people's willingness to seek care in emergencies and other situations? Ms. Spicer, you want to start?
Thank you for your question. In my state, in New York, ground ambulances are covered under our surprise billing law, and we're actually covered under the definition, in the definition of emergencies. So many insured were protected from out-of-network ground ambulance surprise bills even before our surprise billing law. But we still get a number of calls from consumers who are federally insured, who have ground ambulance out-of-network bills, and they can't afford them. It's hard for them to afford, it's hard for them to understand why their plan isn't paying, and it deters them from going to the emergency room and getting care when they need to.
Ms. Thornton, thank you.
Sure. First, it's important to acknowledge that our member health plans want to have a robust network of ground ambulance providers in their network, because we all know when you least expect it, that's something that you may need to need in an emergency or other situation. You know, it is important to recognize that Congress did not include ground ambulances in the No Surprises Act, but we do understand that the regulators are really taking active input on that question and really debating what recommendations to make along that area. So we're actively participating in those discussions and look forward to next steps on that.
Do you think that surprise billing for ground ambulance should be prevented, and we should do something here in Congress on this?
You know, we do want to make sure that patients are protected and held harmless. One of the things that I would caution us in thinking about is if the arbitration process is broken, like has been discussed during this hearing, I would caution us as throwing more, cases at that process. So I think it would require first fixing that process before we add more to it.
Thank you. We'll continue to work with all of you as we try to move forward on this. Also, Dr. Bleier, as you know well, the widespread use of prior authorization delays and discourages medical care for millions of Americans that are entitled to care. That's why I've led the effort in the House alongside my colleague, Congressman Kelly, and others to modernize and streamline this very outdated practice. And we have legislation improving Seniors' Timely Access to Care Act to increase accountability and help Medicare Advantage enrollees get faster care by doing crazy things like establishing electronic prior authorization process, making sure our MA plans are responding to provider requests faster and in real time, requiring plans to report on the extent of their prior authorization use and how often they're denying requests. When we talk about the challenges that providers are facing, could you discuss the challenges you and your patients have faced due to abuses of prior authorization as well, and why legislation is so important?
Yeah, I haven't dealt necessarily with that issue directly from my perspective in the emergency department, but I think we've certainly all dealt with it indirectly, where patients maybe go to a community provider, they're evaluated by that community provider, that community physician feels that that patient's study is warranted and medically necessary, but they're unable to do so, and then the patient is referred to the emergency department because they're then able to get the very necessary study in the physician's perspective.
Mm-hmm. Yeah. And when we talk about doing a good job of helping providers and patients, here's another area we need to address. Thank you, Madam Chair. I yield back.
Thank you, Ms. Delbeni. I now recognize the gentleman from Tennessee, Mr. Kustoff.
Thank you, Madam Chair, and thank you for the witnesses for appearing today. I know that a lot of you have talked about maybe the common experiences that you've had and the frustrations you've had with the whole process. If I could, with you, and if I can, I try to talk to as many providers as I could about all these issues. And one thing that kept coming back was, and you've talked about it, Mr. Brzezinski, you talked about it, is you go through the process, you prevail, whatever that means, and then you've got however long it takes for you to get paid. And cash flow is an issue, whether you're operating a medical practice or a hospital or a retail store or any business. So Dr. Blythe, maybe I'm going to turn it around if I could to you. You know the framework. You know what's been implemented. If you could wave a magic wand, what would you do to fix it? How would it be fixed?
Well, I believe I'll be speaking out of my turn to some extent, but I would, I guess, hire a lot more IDREs, a lot more arbitrators to quickly and efficiently handle the backlog of cases. There's a lot of cases in the pipeline. And then I would also put a lot of resources into enforcement. I'd like to see enforcement. I think it would be beneficial to see enforcement that the QPA is being calculated appropriately without ghost rates, for example, et cetera. Even with the judicial ruling, they sort of set the framework stating that that shouldn't occur, but there's no enforcement or transparency currently, as far as I understand. And then certainly some enforcement in making sure that the arbitrator's rulings are carried out and payments are sent to providers and hospitals appropriately. So I would say enforcement, transparency are the big things, and then to do something to efficiently work through the backlog right now in the system.
Come back to the backlog in a moment. How would you enforce payment?
I would imagine there would have to be some teeth in it. A small, a $350 non-refundable arbitration fee for a group like mine is a lot. That's probably not a lot for, very large insurance companies, given their size and their net profitability quarterly, which dwarfs a small group like ours. So I don't know what that price point would need to be in order to enforce payment and then carrying out what the law states they're supposed to do, but it would need to be significant, I would imagine.
I think in your testimony or in your written testimony, you talked about that the majority of your submissions are under $1,000, I think is how you characterized it.
Yeah, that's correct. That's my understanding.
And do you know how many submissions, how many claims you've submitted, your practice has submitted?
I believe we've submitted about 400 claims because it just seemed like, number one, early on, despite what the bipartisan piece of legislation stated, the regulations, I believe, stated that the QPA should be the primary determinant. We knew we were going to lose those cases, so we had those sorts of issues. We also had the associated very high fees, which excluded us, the backlog, the fact that even when we did submit, we didn't receive payment. So all of those issues prevented us essentially from accessing the system. We're hoping to moving forward, but that's been our experience.
Thank you, Dr. Blythe. Mr. Badinski, in your written testimony, and I'm going to ask you about how you would solve it, but you talked about how this law disincentivizes health networks. I think the way you characterized it was from having robust networks. So you could wave a magic wand, what would you do to resolve issues and fix it?
Yeah, thank you for your question, Representative. First and foremost, the framework is as follows, as we understand it. The courts have found that the administrative process has been tilted in payers' favor. Number two, we've just discussed today the fact that 70% of the providers are found, the IDREs are finding in favor of providers. So the deck is stacked toward the payer in the process, and the providers are still winning 70% of the time. Why is that? What's causing this? What's the root cause? The root cause, I believe, is that the payers' initial payment to providers is being found to be substantially below what is necessary. So the magic wand is to require administrative processes, that the initial payment from payers be consistent with the historical practice of payment for out-of-network providers. If that were the case, I believe these backlogs would disappear. That's what I believe.
Thank you very much. I yield back my time.
Thank you. Mr. Stubbe is recognized.
Thank you, Mr. Chairman. Earlier this year, HHS Secretary Bakira acknowledged before this committee that there have been more claims than initially estimated, and the arbitration process has been overwhelmed. The Centers for Medicare and Medicaid Services have contracted with 13 entities to arbitrate cases. All 13 have different processes for arbitration, and CMS has not had a uniform or concise action in implementing the law. The Department of Health and Human Services has been very slow to roll out this law, and it is the constitutional obligation of the executive branch to carry out what Congress passes. Ms. Thornton, I'd like to start with you. I'd like to ask you a few questions about the bureaucratic failures at CMS, and maybe help me understand the almost inexcusable directives and inability to follow congressional intent with how the No Surprises Act has been rolled out. How much of this can be cleared up by congressional action as opposed to CMS issuing clear guidance?
Right, thank you for the question. I do think, it is important to recognize that you all passed the No Surprises Act to make sure that coverage was more affordable and to really make sure that patients were held harmless from one perspective, but also we didn't do anything to drive up premiums. So I do think it's really important as CMS is putting out guidance and regulations that we're looking at the affordability impact. We've weighed in on all of these different guidance and regulations. We do stress the importance of ensuring a balanced process between providers and health insurance plans to make sure that we're not using this process a lot. Unfortunately, in how it's rolled out, there certainly has been an over-reliance on the use of IDR, 14 times more than was initially anticipated, and that's certainly been really challenging from our perspective.
Is there reforms that CMS can make today to clean up the dispute resolution process?
Absolutely. I think it's really important to focus on solutions. There's been a lot of talk with my co-panelists here around payment and challenges with getting paid on time. I think by rolling out more robust infrastructure and technology to give us a clearer dashboard of all of these various claims and where they are in the process really go a long way to mitigate any payment delays that any of the panelists are experiencing.
Is there a variation across the 13 arbitration firms handling the cases and how they process the claims?
Absolutely. We have seen a lot of really challenging scenarios, making decisions for claims that were really Medicare claims and not subject to the No Surprises Act, really wide variations in the decisions that are coming out. The same provider, the same area, the same service, but a drastically different decision coming out, and definitely we would recommend the regulators do more to ensure consistent processes among the different entities.
Wouldn't it bring more efficiencies if CMS standard the processes across the board?
Absolutely.
Is there certain suggestions other than what you just mentioned that you would suggest?
I think greater oversight and review of the practices of those entities would be well received from us.
Mr. Bobeck, I've got a couple questions for you. What steps, if any, can Congress take to resolve the dispute resolution process between the hospitals, doctors, and insurers while at the same time protecting consumers from balanced bills?
Congressman, thank you for the question. Number one, I believe that Congress continue to see the No Surprises Act through. As noted, millions of consumers are not getting surprise bills. That is a success story that has happened, and that's a universal agreement across the entirety of the spectrum. When it comes to the payers and the providers, continue to put the pressure and the onus on the parties as well as the government to put forth rules that will clearly allow them to speak with each other, understand what exactly they're disputing, and I assure you those claims will go faster and smarter. Again, in our group, we don't have a backlog. We have never had a backlog. Cases go out within the 30 days, and the more information the parties can share with each other, the more cleaner their claims will be and more disputes will go out the door.
How accessible is it for you to get questions answered by HHS?
It is a continuing conversation that we have to have with the government upon various aspects of how they would like the process to be implemented. To be fair, and it has been noted, yes, IDREs do have to make decisions based upon the best evidence that they are provided. In certain cases, there is not a uniform standard that is published, but in guidance, we are all instructed to move in the same ways. But that being said, yes, there can be some small delineations among the ideas of how they go about that process.
And I've only got a couple seconds left here. Dr. Blyer, does it make sense for HHS to charge a $350 administrative fee even to hear disputes that are less than that amount of money, especially with X-ray and other radiological services?
No, it doesn't.
Thank you. Thank you all for being here today. I yield back.
Ms. Chu is recognized.
I'd like to thank all of the witnesses for your testimony today on this important issue. Prior to the No Surprises Act becoming law, millions of patients struggled with financially devastating surprise medical bills. As this law continues to be implemented, it's important that we build on the progress and continue to protect patients from unexpected out-of-pocket costs while also promoting fairness in payment disputes between insurers and providers as the law intended. Ms. Spicer, as you highlighted in your testimony, consumer assistance programs like CSS New York have played an incredible role in helping millions of Americans navigate all kinds of healthcare concerns, from understanding how to use their health insurance, resolving medical bills that are often confusing and conflicting, appealing health plan decisions, and disputing surprise medical bills. Now, New York is fortunate in having your organization. However, Congress has not appropriated funds for these programs since 2010, leaving many states without this resource. Most consumers who are eligible for CAP assistance for these consumer assistance programs are enrolled in employer-sponsored plans, and the majority of these plans are federally regulated, but CAPs that operate with no federal funding cannot manage this large scope of work. So as patient confusion around healthcare continues to grow, can you talk about the importance of increasing federal funding for consumer assistance programs and how CSS New York and other programs could use this funding to help more patients navigate surprise billing?
Yes, thank you for your question. Health insurance generally is incredibly complicated. We have all, as insured, got a notice that we don't understand, an EOB that doesn't make sense in terms of the care that we received, a bill that we feel we shouldn't pay for, a giant package in the mail or an online login that explains our network directory or our summary of benefits, our plan contracts that we have no idea what it says and don't even read it. And currently our state funds our program after we lost federal funding in 2010. It's hugely important for people like you and me to get help with their health insurance because, unfortunately, in America, you need a lawyer in order to properly access care sometimes and get insurers to pay claims and get providers to stop billing you.
So that federal funding was important. Yeah, and
Absolutely.
also you are in a unique position being in New York. I'd like to ask about the differences you've witnessed in terms of patient experiences in the time following the enactment of New York's out-of-network surprise billing law in 2014, and then after the enactment of the federal No Surprises Act. What changes have you observed in patient dispute volumes, types of billing disputes, and other factors between 2014 and now, before the No Surprises Act became law, and in the years following the law's enactment?
Thank you for your question. Before the passage of New York surprise billing law, we saw all sorts of classic out-of-network billing cases that the NSA now covers, in-network hospital, out-of-network radiologist, or out-of-network lab, or out-of-network slew of services that were uncovered. After our state law, those classic cases were covered by the NSA, and there were some things missing, including network directory misinformation, which was the largest volume of calls that we got after we passed our own law in New York State. The second largest volume, of course, was federally insured consumers who just had no protections. And now, since the passage of the NSA, the volume is less, but we still have many calls just about understanding what the process is and whether the bill that the consumer is getting is a surprise bill and how to cure if it is. And then we still get many calls about ground ambulance for for federally insured folks and other kind of follow-up to the ER. You're not, if an ER doctor puts a stent in, you're not going to get another doctor to take that stent out. So you have to incur an out-of-network cost outside of the ER for that. So there's some loopholes there.
So there's improvement that's needed, but there was some improvement with the No Surprise Act bill.
Absolutely, huge improvement, and also in regards to air ambulance.
Okay, thank you.
Dr. Murphy is recognized.
Thank you, Mr. Chairman, and I want to thank the witnesses for showing up today. It's really, I think, very sad state that we passed a very, very good law that had a lot of debate internally, bipartisan support over here, bicameral support, signed into law by a president, and then when there was new administration that came in, decided what was a balanced law between providers and insurers to pretty much put everything in the insurer's pocket. It's an absolute disgrace, and we've met with Secretary Becerra once, 2, 3 times, and the answer was it's always in court. I absolutely applaud the Texas Medical Society for suing against this. Because what has happened is, yeah, I think we all have a consensus agreement that the no surprise, or that surprise billing was an absolute problem. Take it out of the hands of the patients, absolute. But when you turned a process in which is supposed to be equal and balanced, which was absolutely done, and you turn it all over to insurance companies, I'm not sure what the administration is trying to prove, but this has become an absolute boondoggle for insurance companies. Mr. Speaker, I'd like unanimous consent to enter into the record a letter from Blue Cross Blue Shield of North Carolina to a physician practice stating that the interim final rules, and this was probably 2 days after the interim rules came out, provide enough clarity to warrant a significant reduction in your contracted rate with Blue Cross Blue Shield. In some instances, insurers, the next day after the rule was proposed, cut fees 40%. Guys, we all know that medicine is a business, sad enough, but there's no stability in that when the insurance companies absolutely raping profits off of the backs of those who provide the care. So with all unanimous consent, I ask that this be done.
Without objection, so ordered.
There was no teeth in the legislation, sadly enough. 30-day rules once things are adjudicated. We're going to get to some teeth in this, and the people who are holding out the money may not like it, and I invite them to come in my office and help us craft legislation. Dr. Bleier, thank you for being in here. The statutory language was very, very clear. The administration chose not to use it and only to use the QPA as the primary consideration in the IDR process, which insurance companies have deflated on the dollar. And by the way, they're not hurting United, $20 billion with a B in profits, while we have practices that are not being paid for months after they've been adjudicated. So, Dr. Bleier, what's your experience being with the QPAs offered by the insurance companies?
Sometimes we don't know if we're being offered a QPA. It's oftentimes not listed on the initial payment. But the QPAs can vary tremendously, and sometimes they don't really make a whole lot of sense with the marketplace. So, you know, our understanding and speaking to colleagues as well is these QPAs are cited, and a lot of smaller groups in our own, for example, have even less bandwidth to deal with that decrease in reimbursement given their staffing models, and oftentimes are forced to come out of network. They're kicked out of network due to a cited QPA that may or may not be correctly calculated with no transparency to verify, and they're forced back in network at a substantially lower contracted rate. And I think that's been a real issue for a lot of groups from what I hear.
It's a destruction of medicine, and I lay that flat on the hands of our insurance companies. You know, we've seen this with PBMs, the absolute extortion that's going on with them, and it's all vertical integration charged by our insurance companies. According to a survey, 50,000 doctors, those who take care of patients, and 48 said that 100% of providers have been threatened with contract termination. What a way to treat your clients. What a way to treat your clients. We're cutting your prices. Those of you who take care of the patients, we're cutting your prices so our CEOs can earn millions and millions of dollars. On average, 81% of providers had an average of 9 in-network contracts terminated by payers, things that were going fine until all of a sudden insurance companies decided, well, we can take advantage of this. Payment cutters up to range of 52%. Nearly 60% of payments won in arbitration were not paid within the 30-day termination. And I want to ask Ms. Thaler there, you said that it didn't fit, holding back money did not fit your business model. Can you explain what you mean by that?
Ms. Thornton, you meant me? Sorry.
Yes, I'm sorry.
Thank you.
Yes.
Sure. We really depend on having a robust network of high-quality insurers. An employer is not going to want to buy coverage that doesn't have a robust network. So we need to have a collegial relationship with providers. So I think with the goal of bringing more providers in network, it is not in our best interest to withhold payments, because eventually—
But you just heard Dr. Blyer, where basically people get bullied, kicked out of network to come in network at a much lower cost. And at last I checked, patients' premiums have not gone down. They've skyrocketed, and insurance companies' profits have absolutely skyrocketed. The folks in the middle are what's destroying American medicine. The doctor, patient, no longer what's taking care of the patient. It's the folks in the middle who are absolutely extorting money off of the American patient. I'll just say this and I'll close. I'm going to work on proposing legislation. 30 days is fine, but we need to put no teeth in that bill. That's going to add 1% compounded daily to insurance companies who do not pay their claims on time. And I'm happy to work with y'all, but this is ridiculous when y'all don't pay claims 8 months, 9 months out. Are you just waiting for the practices to go bankrupt? Because that's what's happening. I'm happy to work with y'all, but I'm moving forward with this. Enough is enough is enough. Thank you, Mr. Chairman. I'll yield back.
Ms. Tinney is recognized.
Thank you, Mr. Chairman and Ranking Member, and thank you to the witnesses for your work and for the insight that we've received here today. It's hard to believe that just under 3 years ago, we came together in a bipartisan way, bicameral way, to come up with the No Surprises Act, groundbreaking legislation. And this legislation, as we all know, is intended to finally hold patients harmless for surprise medical bills and encourage payers and providers to come up to create larger networks. Since then, as you've heard pointed out by many, we've had unelected bureaucrats really fail to comply with the language and intent of the law, and this has diminished the achievement of the No Surprises Act. And I just wanted to come up with I have a couple of different things I want to bring, just some examples, and I wanted to cite one first, and then I wanted to get into questions to each one of the witnesses. So my first example is in May of this year, an air ambulance provider transported 2 twin infants from the same transferring hospital to the same receiving hospital. Each infant required its own ambulance, and each was delivered safely to the receiving hospital. I'm told the same insurer provided the health insurance for each of these critically ill twin infants. The situation was identical: 2 transports of sibling infants with the same origin, the same destination, and the same ambulance service. Yet the insurer applied 2 drastically different qualifying payment amounts, QPAs. One QPA was nearly $13,000 more than the other for the base rate and greater than $100 more per mile traveled. Not sure who to direct this to, but I'm thinking maybe Mr. Bobeck, you could explain to us, how is this possible, that we have this completely identical circumstance and the QPAs would be, how can this be appropriate and compliant with our regulations under law? And maybe just give us a quick explanation, because I want to ask Dr. Blyer about that as well.
Thank you for the question. Respectfully, under the rules, we are not allowed to even determine the QPA. We are only allowed to use the QPA as it's given to us. The IRB's job is then to look at other evidence that would support whether or not that the payment made in this case was correct or not. So respectfully, I would yield to the other parties on this, as we can only make decisions based upon the evidence that is presented to us in a particular case. Thank you.
Thank you, Dr. Blyer. How does this happen with this? How do we fix this? real injustice to the people that we're trying to serve.
Yeah, it's a horrible set of circumstances. I'm sorry to hear. I have no explanation because I also have no transparent, no view into how that QPA is calculated. It's not.
How would we, maybe we could just pass this out. How would we solve this problem? Ms. Spicer, I'm going to ask you the next question, similar issues with dispute resolution, but this is something that is really maybe a failure on the part of of CMS and our enforcement, and as Dr. Murphy alluded to and others, there's no teeth in this legislation to make sure this doesn't happen. I don't know if you'd have a...
I would also defer to others on the panel. I really am not privy to what information is submitted with those claims that come up with two separate.
As in reference, I found it interesting that you mentioned in your recent discussion with one of my colleagues that you need a lawyer, basically, to deal with some of these issues. And I recently had an organization come to me with complaints that despite the No Surprises Act, some insurance companies are continuing to apply entire balances to the patient's responsibility. In one example, a family was billed for the full amount after the insurance company denied their providers, again, an infant situation, a neonatal critical care claim for their underweight newborn. I mean, how often do we see these illegal billing practices like this? And if so, are you seeing any enforcement of it, referring again to there's no teeth in this, we need lawyers? I don't know if you...
Yeah, so in my experience, thank you for your question. In my experience, the bill comes directly from the provider to the family. The family doesn't understand why. And so then what I do in my practice is to put the plan on the hook, make them aware that this bill is something that the consumer should be held harmless for, and that it falls under the No Surprises Act. But if the consumer doesn't understand that there is even a protection in existence that they can take advantage of, they might pay that bill or go into debt for that bill. And then it's about really fighting with the insurer to make sure that the consumer is held harmless, filing grievances and complaints with the regulator.
Thank you. I don't know if I have time for another question, but Dr. Bleier, in your testimony, you outlined how some health insurances are using the No Surprises Act to financially squeeze providers and in some cases drop them entirely, and instead depend on the No Surprises Act IDR process. This leaves some patients with an insurance plan that does not have a network provider in their area. The opposite of the laws intended result, and I believe I'm out of time. You could either answer or maybe answer us online in another forum. It's up to the chairman. I just wonder, how does the lack of this local and network,
Respond briefly.
Yeah.
Ironically, when there's not enough resources in the community because of a narrow network, those patients end up coming to the emergency department. We take care of them. We take care of them no matter what. It's our duty, our Hippocratic Oath. It's part of EMTALA. So it drives the patients to the ED.
Thank you. My time has expired. I yield back. Thanks so much to the witnesses.
Ms. Moore is recognized.
Thank you so much, Mr. Chairman, and I'd want to thank the witnesses for their patience. I had a couple of questions that made most of the hearing. One of the things that really wasn't clear to me, and maybe Ms. Spicer, Mr. Brzezinski, Mr. Bobek, any of you might be able to answer, is there a particular pattern which will characterize those sort of claims that are disputed, that fall through the dispute resolution process? All of you talk about the thousands and 10,000s of transactions that come through. Is there a particular medical practice? Is it OBGYN? When I came in, baby care, elder care? Is there a certain type of expenditure which might inform some sort of repair of the dispute resolution process where you can start to say, this is where it seems to be failing the most in terms of denials? Uh-oh, wrong question, huh?
Thank you for your question. I can say I haven't seen a pattern in my practice, but our state doesn't use the same process. Before the NSA, we had this baseball arbitration process, and it was all kinds of claims And to echo what members of the panel had said, what I would do in these sorts of scenarios was try to figure out first if it was even worth it for the patient to do IDR, because if the patient was engaging in IDR, they would have to pay the fee unless they won. And so there's kind of these baseline inquiries. Are you eligible? Does your bill count towards the surprise billing law? And then does it even make sense for you to file? But I didn't necessarily, people would get to me when they had really big bills, like surgery, for example. That's when you engage with a lawyer.
Congresswoman, thank you for the question. One pattern that we have noticed clear throughout the process is the more information that the parties have and that they share, the better the process becomes. In the beginning of this process, when people submitted claims, only about 50% actually became eligible. That number for us right now is closer to 87% of these cases are eligible. And the ones that are not that are determined ineligible, that is mainly because of information they did not have. If they're trying to put various claims together and then they miss a certain key piece of information with it, that claim will get kicked out. If they miss certain timelines that they were not aware of, that case will get kicked out. And as also mentioned before, if they try to submit a claim that's Medicare, something relating to the VA or Medicaid, those cases also would get kicked out. These are cases of misunderstanding of the process. People are getting better, and it is the one salient point we have seen through this process. The more people share and understand that information, the more seamless the process goes and the better it works for everybody.
So maybe this is to Mr. Bobek or someone else. You've talked about, and I think you, Ms. Spicer, talked about in New York that you'd have as many as 1 million of these claims come through in like a month's or week's time. Is there a plan for once the portal is open again to do the huge backlog that will be there? What do you anticipate in terms of the workload and the workforce after the portal is reopened?
Congressman, from our perspective, and the providers can certainly speak for themselves and the payers on how they'll initiate claims. From our perspective, we've been on hold now since August 3rd, 2023. We have a large staff that is standing ready. They are training. They are going through everything possible to be ready because we do know that there is going to be a large tsunami of cases that will be coming through that door. For our staff, we've also made increased investments in our technology on our own case management systems to more seamlessly get through these cases, whereby we will not have that backlog, cases will move forward. But we also have to move lockstep with the payers and providers because they are allowed 10 business days or 2 weeks to provide us their payments to use the system and at the same time provide us their offers. They're also going to need to be our partners in this and making sure we get that information seamlessly. From our perspective, we have people ready, waiting, and are looking forward to starting this process sooner because that backlog of new cases will only get worse the more this holds out. Thank you.
Anybody else with anything? I got 9 whole seconds left. Mr. Chairman, I yield back.
Ms. Fishbach is recognized.
Thank you, Mr. Chair. And I think Mr. Kustoff asked maybe the doctor a little bit about, if there's something Congress should do to help enforce payments once they're settled. But I wanted to ask Mr. Badinsky, I'm sorry, I pronounce German names, but not, and Mr. Bobek about if they have some input on that.
Yes, thank you. It's Budzinski, and I appreciate your challenge. With respect to what is the one root cause that is causing all these disputes, I think there's no question about it. The initial payment from the insurer to the provider is being set by the insurer. It's being proven that the insurer is underpaying providers under the Act. And until that issue is resolved in some way, shape, or form, the process is going to continue to unfold, I believe, in a similar fashion. Insurers no longer have a need to contract with emergency departments of hospitals or emergency physician groups because they can underpay, and it gets into this process, and then the disputes blossom, and now we have backlogs like this. So the initial payment should be established with a minimum floor. That minimum floor should be consistent with out-of-network historical practices for payment, or frankly, insurance companies often have a secondary contract. They have a secondary contract with a third party that providers often do as well. These are out-of-network service arrangements with discounts to providers. Insurance companies are ignoring those contracts, and they are simply paying the initial payment amount under the Act without regard to their access to another contract.
Thank you very much. Mr. Bobek, do you have some input on that?
One thing we continue to repeat throughout this is that ultimately, the more the parties have experience and expertise in submitting these claims, the better process becomes. We don't believe the answer is having more IDREs, because ultimately that would be bringing in more groups that don't understand the system and how the rules are put forth. You need groups who have the understanding and expertise to move forward and get these claims paid and adjudicated in a timely manner. That's where all of our people over the last year have spent their time. We are referees. We do not come up with the rules, but we are the ones to enforce the rules, and that is ultimately the process that we move forward on best. And we have noticed when people understand the rules, it makes it a lot easier for us to make the decision. Thank you.
Do you think there's room for more enforcement? Should Congress be acting on something?
One of the pleasures of being the referees is we're not allowed to comment upon the rules, but we may not be able to define the strike zone, but I assure you we will call the balls and strikes as you give it to us. Thank you.
Thank you very much, and you're very diplomatic.
I can explain the sports references.
Oh, my good friend's going to explain the sports references to me, but and maybe what I should do is ask if there is anyone else on the panel who would like to comment on that. And I don't see any. Oh, here we go, Ms. Thornton.
I just wanted to respond to the question that, or the comment that we are making artificially low payments as our QPA. You know, the regulations have, and your legislation had pages and pages of very detailed information that we have to abide by when we calculate those QPAs, which are based on actual contracts between providers and plans. So I just wanted to emphasize that we are following those regulations when we're calculating that, and we're following it by the line.
Thank you. Since I don't see any other volunteers, I'll yield back, Mr. Chair.
Mr. Fitzpatrick is recognized.
Thank you, Chairman. Thank you for holding this hearing. The No Surprises Act was signed into law, as we all know, back on December 27th, 2020, to protect patients against surprise medical billing. However, the law has not been fully and correctly implemented in the way that this Congress has intended it to be. And as a result, patients are hurting. In my district and districts across America, emergency departments' wait times have more than doubled since this law's passage in 2020. I personally have many hospitals in my district that have reached out to our office about the influx of people and increased wait times in their emergency departments, resulting in overworked hospital staff and patients literally being left in hallways. Studies have suggested that 20% of emergency department visits and 10% of elective inpatient care stays involved at least one out-of-network provider. I want to thank our witnesses for being here today to provide us with your firsthand knowledge and your experiences on how this law was implemented and is being carried out. First, to you, Ms. Spicer. The No Surprises Act obviously was intended to give patients peace of mind that they would not receive surprise medical bills weeks or months after what they thought was a covered in-network service. Due to your interfacing with patients every day, can you speak to what has changed for patients since the enactment of the law and what outstanding concerns you continue to hear from patients today?
Yes, thank you for your question. What has changed for patients? They obviously, in our state in New York, we had a surprise billing law before the NSA. So what I see the change is that now federally regulated consumers are protected from surprise and emergency service bills. What is outstanding for consumers is, which are complaints that I normally get, are ground ambulance, post-ER visits to out-of-network doctors who provided the ER service. And one of the things that we do most is just to counsel people on what the law means for them and how it can help them and how to engage in the process when a mistake is made and they are not held harmless, or when they receive a bill. Usually those two things go hand in hand.
Mr. Budzinski, what is your perspective from the hospital standpoint, your concerns about implementation, and what are some of the solutions you think would address that?
Thank you, Representative. I need to ask you if you want the whole list or just the top 10.
You can start with the top several. How's that?
Very good. Number one, as I said several times today, the reason there are disputes is because the insurance company is in charge of making the initial payment amount to providers. There's no regulation that currently specifies what that amount needs to be. There's confusion about that in some of the administrative rules that have come out and that have been addressed through other processes, where the QPA might be the correct initial payment amount, but it was not the intent of Congress to establish that. But unfortunately, we believe that the insurance companies are now driving a big truck through that loophole and are establishing initial payment rates that are very low, creating disputes. And that what we've heard today is that when the dispute is listened to by an independent person, an independent entity, 70% of the time, the providers are right, that they were underpaid. And this is when the deck has been stacked against providers in the administrative rules. So that's number one. Initial payment amounts are being set by an organization whose benefit is to set them as low as possible. There needs to be a minimum established amount consistent with what out-of-network payment rates used to be prior to the legislation, or at a bare minimum, insurance companies should be required to access all their contractual agreements for specified discounts and not ignore those contracts. In addition to that, batching was mentioned earlier. Batching needs to be revised. There's no question about that. And the bundling of services. Hospitals in particular are typically paid on bundled arrangements. In an inpatient setting, that's what's called a diagnosis-related group case rate. Most of the time in outpatient ER settings, those are called ER case rates. In addition to that, observation care that sometimes follows up on emergency care is often reimbursed on a case rate. We believe that the bundling of those types of things consistent with how hospitals are typically paid is the right answer, as opposed to every line on a bill having to be adjudicated through the process. By the way, what that does from a provider perspective, if we send in one dispute for an ER service, an ER visit, that's one administrative fee. If we have to go through 4 or 5 or 6 CPT codes on an ER bill, each one of them become, in effect, an administrative dispute with payment. So batching, administrative fee refinement, we believe that the loser should pay all administrative fees, quite frankly. Those are just the top few.
Thank you, Mr. Budzinski. Ms. Thornton, I was going to ask you about the insurance perspective, but my time is expired. So, Mr. Chairman, I yield back. We'll take that for the record, that question. Thank you.
Thank you. Mr. Byer is recognized.
Thank you, Mr. Chairman. Mr. Chairman, Ranking Member Neal, thank you for holding this hearing. Incredibly essential. Mr. Budzinski, you just repeated something that was in Ms. Thornton's testimony. About 71% of the disputes that reached determination favored the healthcare providers and the area ambulance suppliers. But you've also said that the law was never intended to pick winners and losers, and that the health insurance companies are winning overwhelmingly. Can you explain the arbitrariness of the process and how we can make it less arbitrary?
Yes, thank you, Congressman. I'm going to come back to the law was never intended to pick winners and losers. But inside the framework, the initial payments paid by insurance companies are unregulated, unspecified, and that process has created a situation where ER physician groups, emergency room of hospitals are being underpaid initially. And through that process, it only leads to dispute. And
so let me follow up on that, because Ms. Thornton again said that they estimated 17,000 claims and said they had 334,000. Are you suggesting that the insurance companies, by intentionally underpaying, are creating an IDR process? Creating the surprise billing complaint appeal in the first place?
That's the belief of our organization, yes, sir.
Dr. Blyer, again, leveraging off Ms. Thornton's testimony, she pointed out that there's only a handful of companies, a handful of states that are filing all these claims. 60% of the claims from 5 states. All the numbers are in her testimony. How do you respond to that? That this is not just a handful of emergency room practices that have figured out how to game the system?
It's hard for me to say what the intent of anyone else's business is. I can tell you from our perspective, and I suspect by extension a lot of other independent ER groups as well, emergency medicine groups out there, I think the number of arbitration cases, I believe you cited roughly over 300,000, would be far, far higher if we felt that the arbitration process was working more efficiently. We've only submitted 400 claims, and it's largely because the process hasn't worked up until now the way we would like, and yet we have, institutional damage, so to speak, because the loss of revenue that we've experienced because of those underpayments up front, we can't get that back. There's no process. Unfortunately, with the Texas Medical Association lawsuit rulings, they didn't allow for us to submit claims, for example, at lower IADR fees going back to the beginning of this year. That was not part of the ruling. So, but I can't speak to why other groups are submitting claims through the arbitration process. But I can tell you that's been our experience.
Mr. Budzinski, Mr. Bobek mentioned that all they do is apply the QPA. They have nothing to do with it. You complained in your testimony about the cloak of secrecy that QPA has. Where does the QPA come from, and how transparent should it be?
Yeah, so there's a couple things. First of all, we actually have had a number of our requests for determinations with Mr. Bobek's company, and let me just say for the record, their organization is one of the most transparent and engaged IDRs, entities that we have come in contact with. So from our perspective, we understand their role as a referee, as an arbiter of the facts. With respect to the QPA is there, I believe, in the legislation to protect the consumer. The QPA was not established as the correct payment rate for a provider. Now, I will tell you, we don't really understand how QPAs are calculated, nor do we ever receive calculations of what QPAs are. But relative to payment to providers, it has not been established that a QPA is the correct payment for providers. And in fact, we believe in most situations that is not the correct payment to providers. And our determination requests reflect that.
Thank you. Mr. Chair, I'll yield back.
Mr. Moore is recognized.
Thank you, Chairman. And I'd like to thank the Chairman and the Ranking Member for holding this hearing today. Let's take a quick moment of pause to just recognize what we're doing. We passed something. It's created some good for many patients, and we're now reflecting on it. We're identifying the challenges of the implementation of it, and we're trying to make improvements on it. Anytime you give me a chance to do that, I will be ready to do whatever work is necessary. So thanks for moving the ball forward on this and for having us be able to discuss it today. I'm going to talk a little bit mostly about the independent dispute resolution, so the IDR process, because this implementation of this has not been without its challenges. And there's been periodic pauses from this IDR process, and it required that several regulations be rewritten as agency officials strayed from congressional intent in implementing the law. So today I'd like to focus on how this ever-changing regulatory landscape creates a lack of clarity for parties resolving claims in the IDR process. And so I'd love to hear from the witnesses on this particular issue. How has it affected your operations? Mr. Bobek, as you noted in your testimony, over the last 2 years, as HHS, Treasury, and Labor have implemented regulations for the No Surprises Act, the IDR process has periodically been suspended. This prevents new cases from being initiated through the federal IDR portal and prevents IDR entities from adjudicating disputes between providers and health plans. Can you speak to the operational challenges that this sort of stop-and-go implementation of this law has had, particularly on IDR entities?
Congressman, thank you very much for the question. From the IDRE perspective, the biggest thing that happens with the start and stop nature of the process is essentially that you need to be able to staff up for a process that you're never quite sure when it's going to begin again, and then also have a staff that is ready to handle a tsunami surge of cases when it starts back up again. So the biggest thing we have to look for in all of our staff is, are you prepared for flexibility? And this process is only going on for 1 year. So if you were to look for experts in the IDRE process over 1 year, you will not find them. Right. So the people that we have on staff, we need to maintain them. Even if they don't have anything to do, we are maintaining them for their expertise and their knowledge. That does create costs, obviously, for the IDRE as we move forward. But as noted, again, this process is still in its infancy. It is moving forward. We have seen the benefits of cases moving through the system, payment determinations being made, and we know that it is a great responsibility for our job to make sure that all the parties, payers and providers, can have their job done to help consumers, so we're ready to stand by. And whatever challenges we face, we feel are much smaller compared to what the providers and the payers have to work through, and then their patients.
Backlogs. Can you speak a little bit to backlogs in particular? You've generally addressed it. You've talked about a year timeline only, but specifically backlogs. How has complying with this sort of changing regulatory landscape affected that?
When it comes to the backlogs right now, when the parties ultimately are going to start submitting all their cases again, the timeline still for us is still going to be clear. The moment that we receive a case, we only have 30 business days to make an ultimate decision on it. When you have an increased number of cases, it does put more impetus on having a staff that is cost-effective and streamlined, that they'll be able to handle that. And again, we can only speak for ourselves. Yes, there are 12 other IDREs within this process, and ultimately some of them are working through some of their older cases that they have. But with that being said, for us, the only thing you can do is continually have a staff that is ready to move through those cases, because for us, timelines are non-negotiable. You have to do them.
Dr. Bleier, and I'd welcome comments from Mr. Budzinski as well. I've heard that small and independent practices in Utah, I represent Utah, have negatively impacted, they've been negatively impacted by the IDR process, including from the dispute resolution backlog, as I mentioned, and the 600% increase in IDR fees. Well, this fee increase was reversed. Could you speak to the operational challenges of this stop-and-go implementation on provider practices, as well as what financial impact the IDR backlog has on providers?
For a relatively small group like ours, it really cripples our operations to a significant extent. We don't have the bandwidth or capacity to, when we're receiving 70% less than our prior long-standing in-network contracted rates, to submit a payment for $350, let alone $50, right? And in addition to that, we've been effectively excluded from the IDR process due to all of the things that we've discussed today, right? Initially, the way that the QPA was given unfair weighting, the backlog, the fact that even when we do submit and win a case, we're not reimbursed. So that really affects our ability to provide the resources that we want and towards effective provider and patient care at the bedside, I should say patient care at the bedside by our providers.
Any final comments? Maybe even, is it affected rural patients?
There's no question that when resources are reduced, it's going to affect the capability of providers to provide care to communities they serve.
So, thank you all. Appreciate it.
Ms. Van Dyne is recognized.
Thank you very much, Mr. Chairman, and thank you to our witnesses for coming to today's hearing. In August, I was able to gather with healthcare leaders from across Texas. And during this meeting, I heard over and over how unelected bureaucrats are failing to comply with the No Surprises Act. And while this is not surprising and frustrating for everyone involved, it's the patients stuck in the middle that is hurt the most. And I'm glad to see that we're holding this hearing. With my state leading the most amount of disputes, and in Q4 of 2020 with a total of 25,277 disputes, according to CMS reports, further adding to the nearly 250,000 unresolved payment disputes that are currently clogging the IDR backlog. And while I'm also glad to see that my state's medical association currently challenging in court, and I do want to associate myself with my colleague, Dr. and Congressman Greg Murphy, and his comments lauding TMS. It's based on these decisions, it's apparent that the CMS bureaucrats have elected to go around the intent of Congress and make unilateral decisions on what they think would be best, causing patients to lose care and trust in their providers. Every day that passes with the NSA and IDR portal that remains closed, it pushes medical practices across America closer and closer to insolvency. If the tri-departments keep the portal closed for an extended period, potentially up to 6 months, the consequences could be catastrophic. And such a prolonged exposure could disrupt emergency medical services disproportionately in the state of Texas, my state, putting patients at risk and further straining the healthcare system. And it's not just this committee that's dealing with this. We are looking at CMS in it changing its intent, hurting a number of private practices, small group practices, increasing costs, decreasing quality of care. This is a problem, and we need to figure out, there's a lot of solutions to it. Getting this administration to actually put forward those solutions and getting CMS to actually do its job is another challenge. But Mr. Bowick, I really appreciate your comments dealing with the IDR and some of the problems that they're facing there. But in your testimony, you talked about batching and how that led to roughly 40,000 cases deemed ineligible due to current batching rules. In your opinion, should CMS consider revising the batching criteria to be more closely aligned with what Congress intended?
Congresswoman, thank you for the question. On particular with regards to batching, it doesn't totally represent all the 40,000 cases ineligible, but does represent a substantial portion. The feedback that we provide CMS ultimately when it comes to episodic care and finding different ways to batch is primarily what we hear from both the payers and providers, which are more closely aligned to their billing practices. And we believe the more in line you make practices, a dispute resolution process with billing, you will get better results and the parties will much more understand the process and they'll come to much more resolutions as well.
I appreciate that. When Congress drafted the No Surprises Act, this committee was very specific about what criteria should be used in IDR to settle the payment dispute. And this is something back in my home state of Texas that the Texas Medical Association has consistently advocated for. My question, Mr. Bobeck, is before the IDR process was halted, what criteria were you using to determine a case?
Congressman, do you mean before the Act's implementation or the new court cases as they were going forward?
The new court cases in which IDR actually closed the portal.
From the beginning of the process, the Act itself outlined very clearly the factors that had to be represented, one of which was the QPA, and number two was what they called additional information. Additional information included various aspects, one of which was previous contracted rates over the last 4 years, the market share of both the payer and the provider, patient acuity of how they presented in a particular facility, the teaching status of that provider facility, the level of training, and then obviously, as we already mentioned, the QPA. Initially, when it came out, the rules written by CMS required that you look at the QPA first as the first aspect of it, and then you would look at the other factors to see if there was some type of rebuttable presumption, if you will, upon the QPA. The court cases that came out in February made it very clear to the arbitrators that you were to look at all these factors together equally. The weight that you give them is ultimately up to the arbitrator in that particular aspect. And so with those changes that come through the court cases and then obviously the CMS rules, we have adjusted how we have to review those cases because that is the rules of which we were given.
Dr. Bleier, real fast, would you say that this weight on the median and network rate represents the unique circumstances of a case?
If you're asking me if I think the QPA should be overweight, the answer is no.
All right. Thank you very much.
Thank you.
And I yield back.
Mr. Kildee is recognized.
Thank you, Mr. Chairman, for recognizing me and for holding this hearing. It's a very important subject. I share the views expressed by some of my colleagues, and my questions might be a little redundant, but as you can see, we sort of come and go, and I may have missed some of the answers. But as the ranking member, Mr. Neal, said, we knew with pretty good clarity what we were trying to produce when we put together this legislation, and it's something that was a bipartisan product, something that doesn't happen often enough around here, and it's something that we take a great deal of pride in. So it is a cause of a lot of frustration for us to not see the legislation being implemented consistent with what we know was, in fact, our legislative intent, and what we actually think the legislation does a pretty good job of articulating. We want to see that adhered to. But if I could pose a couple of questions, one to Dr. Bleier and then another to Ms. Spicer. And you may have answered this before, but if you could just elucidate me on this subject a bit further. One of the obviously challenging areas that we're seeing with No Surprises Act is the rising reports of terminated in-network contracts. And Dr. Bleier, you made mention of that. It obviously is a problem in terms of contributing to the challenges that we face in terms of trying to adjudicate these disputes, but it also would seem to me that it would have an effect on overall healthcare costs generally anyway. And I wonder if you might comment on the extent to which you're seeing this and how it's playing out in the field. And then, Ms. Spicer, more generally, I wonder if you have suggestions as to what the administration might do or Congress may have to do to ensure that as we implement, we're not seeing a narrowing of providers that really does create a threat to patient care. So starting with Dr. Bleier, if you could comment, and then Ms. Spicer.
Sure. As I stated earlier, I appreciate the question. We didn't have an out-of-network issue before the NSA. We were in network with all of the major carriers, and that was always our strategy. We don't want to have patients in the middle. We want to leave patients out of the middle during their most vulnerable times in their lives and their families' lives oftentimes. And most of our contracts go back up to a decade or more. And we certainly didn't ask for any rate changes despite there being no inflationary clauses, despite the transfer of a lot of responsibility to the patients as far as high deductible plans go. And the insurers didn't ask for rate changes either. Most of those contracts were on evergreen yearly renewals, and they signed them without question until the NSA. Then the NSA comes out, and surprisingly enough, we really didn't think we would be affected by this very reasonable, well-crafted bipartisan piece of legislation because we weren't out of network with any. We weren't part of this, reported issue, but nonetheless, because of the NSA, ironically, we have then been kicked out of network by a couple of payers and by a third payer as well, Threat, but thankfully, did not actually end up kicking us out of network.
So just out of curiosity, ostensibly, what is the justification that's being offered for taking that step? I mean, I understand what the reasoning might be behind the wall, but what is offered as the justification?
There is no justification that I'm aware of. It's a 40% plus reduction in reimbursement if you want to stay in network. Right. And sometimes it's much less. And then once we're out of network, it's a 70% reduction in the upfront payment. And then there's an IDR process, which we can't really access and take advantage of. So it's becomes a permanent loss of resources for our group to use towards patients' care.
Ms. Spicer? Thank you, Doctor. Ms. Spicer?
Thank you for your question. In New York State, we have state laws that require robust provider networks. So I would suggest federal laws are less robust in that area. So I would suggest network adequacy protections in that form. And also one thing that advocates in New York State bring to our regulators often is surveillance of those networks. Sometimes consumers complain of ghost networks. And of course, we still see misinformation regarding networks. And I would advise surveillance of networks to ensure that the networks are as robust as possible.
Thank you for that. And I want to thank the panel for your contributions to this conversation. I want to thank the chair for holding this hearing. It is so rare that we come together. We should do more of this, that we come together around a really difficult issue and find a bipartisan solution. And it's my hope that folks down the other end of the street are listening to this and will work with us to make sure that the law is being implemented in the way it was intended. With that, thank you, Mr. Chairman. I yield back.
Thank you. Mr. Smucker is recognized.
Thank you, Mr. Chairman, for yielding and for holding this important hearing today. And I think, as Mr. Kildee just said, you're hearing almost unanimously the view of members of this committee and from both sides of the aisle. This is an issue that there was considerable work done back in 2020. We all want to ensure that our constituents have access to quality health care. They have access to the care that they need and at a price that they can afford. We want them to understand the costs, and then we don't want them to be surprised with large bills that they weren't expecting. And so we're all frustrated that this hasn't been carried out in the way that was anticipated when this bill was passed. And I don't know that I have a lot more to add to this discussion other than what's already been discussed, but I represent an area in southeastern Pennsylvania, the 11th district in Pennsylvania that has some large rural areas. And I am concerned about care being accessible there, and I'm concerned about the impacts of this not being carried out properly and how that impacts us. And I think, Dr. Bleier, I may ask you to expand on this, although you've sort of just addressed the question. But you've said, I think, 52% of claims are not even paid. And you testified that there's not even a clear mechanism right now to ensure that there's a way to force that payment to come. So it's got to have an impact on hospitals' providers' ability to carry out care. And so again, as I said, I'm concerned that the impact this will have on patients who need to rely on your systems for their care. So I don't know if you want to expand on that at all. Have you had to alter or eliminate services? Do you know of other providers who've had to do that because you're being compensated at slimmer margins than you should be otherwise?
I would hazard a guess that there are many groups out there that have had to do that, but I can't say for certain. As far as our group goes, we're really trying to have a more medium sort of term view of this situation, in the sense that although our revenue has been slashed because of what's occurred, I think the owners of our group, who all work in our emergency departments every month, have taken the brunt of it, and we've tried to shield our nurse practitioners and physician's assistants and other providers and administrative staff from that, but it can only go on for so long, and we're very hopeful, fingers crossed, that these Texas Medical Association lawsuits will actually bear fruit, that the regulation of this bipartisan piece of legislation will be implemented consistent with the intent of the law. And if that happens, I'm hopeful that we'll be able to continue to provide the level of resource that we want to all of our patients, including those generally under-resourced communities within our state. Having said that, though, if this continues, I don't see any way we could continue the level of care that we currently are providing. It absolutely will, for our group, lead to, unfortunately, reduction in hours, staffing hours, potentially reduction of positions entirely. It may even lead to us having to withdraw, unfortunately, from certain contracts where, it's not sustainable. And that undue pressure with that razor-thin margin is just too much.
So I think you've just articulated why this issue is important and why it's important we get this resolved as quickly as we can, why it should be implemented in the way that was intended. This will affect, and potentially is already affecting, individuals who need care, who may not be able to access care because this issue is being carried out in a far different way than what was intended. So with that, I yield back. Thank you, Mr. Chairman.
Mr. Hearn is recognized.
I'd like to thank the chairman and ranking member for hosting this bipartisan oversight hearing on surprise billing legislation. Almost 3 years ago, Congress passed the No Surprise Act to protect patients from surprise medical bills. Before this law, you would hear stories of a patient being rushed to the hospital for an emergency and then surprised with an out-of-network charge. With the passage of this law, we are seeing the private market work to negotiate claims and leave the patient harmless. I'm proud I voted to support the No Surprises Act to end balanced billing and root out fraud in the system. Today, I want to highlight another key provision in the No Surprise Act, the Advanced Explanation of Benefit Tool, or the AEOB. The AEOBs are patient price estimator tools that empower consumers
to shop for their health services by letting patients know the cost before they get care. This Congress is focusing on building out transparency data. Still, until this information is personalized and considers the patient's health insurance coverage, this data is meaningless for everyday Americans. That is why I'm so disappointed this administration is dragging its feet to implement the patient price estimator tools required by the No Surprises Act. This committee has sent 2 bipartisan letters inquiring into the continued delays in providing patients with these tools. Mr. Chairman, I'd like to insert for the record these 2 letters from the Ways and Means Committee to HHS inquiring about the delayed implementation of the AEOB.
Without objection.
Thank you. Yet we have to get a clear answer about when we will see full implementation of this provision. Fortunately, innovators in my home state of Oklahoma are working to ensure Americans can navigate the opaque healthcare system. For example, Medify Health in Oklahoma partners with over 1,500 employers to provide approximately 300,000 members access to personalized cost estimates within the provider selection process. Consistently, this tool delivers significant healthcare cost savings to patients and the small business owners administering their health insurance. It is an absolute failure of this administration to delay implementation of this technology elsewhere. Considering Americans' families' current economic struggles, anything to help with financial planning should be a priority. Knowing how much health services will cost removes some anxiety patients face when seeking medical care. Patients are nervous about their test results. There is no reason for the added anxiety of not knowing how much a service will cost them. Ms. Spicer, in your testimony, you mentioned the importance of consumer protections in the shared story of a patient who was not given an advance estimate of the cost of this procedure. The patient received his explanation of benefits from his insurance company after the procedure and therefore had no idea how much this surgery would cost in advance. Ms. Spicer, everyday Americans shop for goods and services and know the cost in advance. Can you speak to the positive impact of an advanced explanation of benefits would have on patients?
Yes, thank you for your question. The advanced explanation of benefits would be a hugely positive tool for consumers to understand healthcare costs associated with the services they want in advance of getting those services. It would give them the ability to make informed decisions considering their bank accounts and their other kinds of choices that they have in their healthcare before they incur these potentially crushing medical bills. In one of the examples in my testimony, I talk about the notice of consent waiver that's required when you go to a practice. Each patient gets a notice of consent waiver, and that will tell you if there's out-of-network providers potentially involved in your care, but it doesn't, and that you may have out-of-network costs because of that, but it doesn't give you any specifics about those costs. It's also bundled with a bunch of papers that you sign automatically that you have to sign to walk through the door, like the HIPAA release and the consent form, other consent forms. So it really, what's in place now doesn't necessarily give all that transparency and that information in order for consumers to make an informed decision. I would say that even the advanced explanation of benefits form, consumers are going to need help understanding what it is because it's going to be complicated.
I thank the chairman and the ranking member for working with us in a bipartisan way to make this happen. There's nothing in America that consumers purchase that they don't know what it is before the price of it before they pay for it, except for their health care. It's time for us to get this resolved and fix this issue once and for all for the American people. Thank you, and I yield back.
Mr. Evans is recognized.
Thank you, Mr. Chairman. I want to thank the ranking member, Neil, for all his work on surprise billing over the years to help our constituents. Providing access to price information is important to Pennsylvania hospitals. In Pennsylvania, every hospital has a patient advocate or financial counsel. The individual is available to discuss pricing with everyone to clarify costs. Ms. Spicer, in your experience, how helpful would it be for the patients to have this kind of information that clarify costs when they leave the hospital? is there other information that you think would be important for hospitals to provide?
Thank you for your question. Yeah, it would be very helpful for patients to have advocates to explain to them costs. I think it would be even more helpful, as we discussed today, to have them in advance of the hospitalization. But certainly in New York, we have a hospital financial assistance law, and there are offices within the hospital that are charged with extending that hospital financial assistance and giving other information like patient advocates offices. And we often at Community Health Advocates act as a kind of intermediary and get information and share it out so that consumers understand their rights and also their potential costs and the costs that they've incurred, right? We always get consumers who come to us to say, I don't understand why the bill that I'm receiving is so high. How could the cost of XYZ be what's on this bill? Or the bill is for, thousands and thousands of dollars, but the invoice doesn't tell me what I received that they're charging me for. So it's definitely a transparency in billing and pricing prior to being billed is needed.
Any thoughts you have in terms of implementing incentives to make it happen?
For the advanced EOB, I can't speak to why it hasn't been implemented. I think it would be great for consumers for those pieces to roll out.
I yield back. Thank you, Mr. Chairman.
Ms. Steele is recognized.
Thank you, Mr. Chairman. Before Congress stepped in, a patient receiving emergency care from an out-of-network provider or facility would receive a surprise Medicare bills. 7 in 10 patients were unable to afford their out-of-network Medicare bills, according to a previous Kaiser Family Foundation survey. Unfortunately, this scenario happened to John Hagee, who survived a serious bicycle incident and had to visit an emergency room care for in Los Alamitos. He received a $5,000 Medicare bills for his visit and later discovered that the hospital and physician group were both out of network. John, like many others, had to face Medicare debt and significant financial burdens due to receiving vital care. The Bipartisan No Surprise Act has been successful, but we can all agree that its implementation has not, leading to physician burnout and reduced patients' access to care. I have heard from physicians across California, particularly in emergency medicine, that issues with an implementation of the No Surprises Act have caused such financial instability that many physicians are retiring early and leaving medicine. According to a local survey, 45% of California physicians said they are considering retiring early. 3 out of 4 California physicians report patient challenges with timely access to care, and 60% of California physicians report difficulty staffing emergency on-call panels. Now patients are being onboarded in emergency rooms waiting for specialists to become available. To Dr. Bleier and Mr. Budzinski, since the recent court rulings in Texas against the administration's implementation of the No Surprises Act, the independent dispute resolution process for resolving payment disputes were put on hold. Now, this month, the administration has announced that it expects to direct certified IDR entities to resume issuing payments determinations for some disputes very soon. This means that providers are still treating patients without mechanism to get fairly paid. For a provider, what does this freeze in the system do to you and to your practice?
I appreciate the question. It puts us in a very difficult situation. Unfortunately, I think the insurers and we all know that emergency medicine providers and staff working in those emergency departments will take care to the highest level any patient that presents to the emergency department, no matter what, regardless of their ability to pay. We always do the right thing for those patients. However, we can only staff those emergency departments with the resources that are available to us. So when our reimbursement is slashed below market rates, longstanding market rates in our area, and our revenue and resources are dropped, we are not, and then we have no recourse. The No Surprises Act, this wonderful bipartisan piece of legislation, set up this process by which we would have recourse in that situation when suddenly a payer where we had been in network with them for a decade or more suddenly slashes our reimbursement by 40 to 70%. We would have this ability to still advocate for ourselves and potentially still receive fair payment. But if our payments are reduced up front and then we have no recourse, inevitably what's going to happen is we are not going to be able to staff those emergency departments and put the resources in that those patients in those communities need, which is most horrible for our patients, but as you alluded to with some of your constituents, horrible for the providers and nurses and other staff working in those emergency departments who want to do what's right for those patients.
Thank you, Dr. Bleier. Mr. Budzinski.
Yes, thank you, Representative. We are a large organization, but as I mentioned earlier today, the amount of reimbursement that we have tied up with the IDR process that is broken is over $40 million in underpayments to our organization. And even an organization our size, these are substantial amounts of funds that ultimately require us to balance our budgets in some way, shape, or form. And this ultimately missing revenue does impact our resource allocation. There's no question about that.
Thank you very much. Mr. Chairman, I have another question, but my time is up, so I'm going to yield back, but I'm going to ask for the recording of my question.
You can definitely submit the question in writing, and they'll answer that. So
thank you.
Thank you, Ms. Still. Mr. Feenstra is recognized.
Thank you, Chairman and Ranking Member. Thank you for the panel for being here today. We have challenges. We all see it. We understand it. We know there's flaws. My question, I want to really center around the batching. When you start looking at the various departments to batch claims to avoid the buildup, but the problem really becomes the implementation of the batching. So, Mr. Bobeck, in your testimony, you mentioned about 75% of disputes were determined ineligible due to noncompliance with the administration's batching rules. Can you describe the eligibility criteria for determined validity of these claims? I mean, what can be done here?
Congressman, thank you for the question. Currently, right now, the eligibility is actually at 87%, so most of the cases are actually eligible. But of the percentage of cases that are determined eligible, batching is accurate as one of the reasons many cases are ineligible. And it does not result from the parties not trying to give their best efforts. It revolves around the parties trying to comply with how batching has to be done. So for instance, most of the codes, service codes that come through to an IDRE can be centered around 5 codes, 999281 through 99285. Those codes, you can batch those together when they are the exact same service code and they involve the exact same health plan, the exact same provider. And also they come within the same 30-day time frame. That just simply is not how providers and payers track their claims. They don't track them over all of these different patients. They track a patient's claim and all the ancillary care that goes along with that. So it's a different mindset that's been enacted under the rules, and therefore that's what they have to comply with. And that's why they have to spend a lot of their time just to get information to an IDRE. And when we get that information, we can only say whether or not that claim was done accurately or not based upon what was provided to us. So it provides not just challenges for the IDREs, but again, for the patient providers, and that's what leads to ineligibility. It's not good faith efforts. It's just simply an inability to track cases as they are accustomed to be quite frank, over the last several decades.
So, Dr. Blyer, in what Bobek just said, what can we do to ensure that providers probably can use a batching process in a meaningful way? To me, there's merit here, but how can we get it done?
That might be a little bit above my pay grade. I think simplifying processes in general is beneficial. You know, I think sometimes in these regulatory processes, they can be uber complicated and difficult for providers to follow. Certainly, a lot of providers, you know, will use revenue cycle management companies to submit a lot of those payments. So, you know, batch those claims. So it's a little bit outside my wheelhouse, but in general, I think simplifying the process, making the process more transparent on the submission side, I think is always generally.
I would agree. I mean, I think transparency. And I just see all the red tape, all the issues. I mean, I think we can make this simpler and make it more efficient. Budzinski, similar, can you describe what batching procedures would help hospitals in their IDR processes? I mean, I'm trying to aim at solutions here. That's what I'm trying to do.
We greatly appreciate that, Representative, and thank you for the question. As we said earlier, hospitals for emergency-type care are typically paid on a case rate basis, okay? Observation care post-emergency as a continuation is a case rate basis. Inpatient care is a case rate. So that's how we are typically reimbursed, not CPT code by CPT code by CPT code by CPT code. So the current process is required. In order to batch, you have to have the same exact CPT codes for every single patient with the same payer. The same exact identical care.
That doesn't happen very often.
It doesn't happen at all. Every patient is different. Gotcha. Every patient has unique needs. What we'd be an advocate for is go back to a structure of batching and bundling that's consistent with how hospitals are reimbursed. For example, emergency department visit, level 1, level 2, level 3, level 4, level 5. It's a case rate, and that's how we are typically reimbursed. The CPT codes and all the ingredients are not really relevant. It's about the patient and the care, the level of care that patient is receiving. That's an example. Observation case rates would be another example. Batching based upon how we are typically reimbursed would be ideal, and that would simplify the process, and I think we think help reduce future backlogs by reducing the number of determination requests.
See, boom, we got a solution. I mean, we can do this. I mean, it's not rocket science. But thank you, and I yield back.
Mr. Panetta is recognized.
Thank you, Mr. Chairman. Appreciate you holding this hearing, and of course, thank you, Member Ranking Neal, for all of your work on this important issue. And ladies and gentlemen, thank you for your patience and your testimony and your information about the issues and potential solutions for implementation of this very, very impactful bill. At least we want it to be impactful. I come from the Central Coast of California, the 19th Congressional District, and when I'm talking to my patients there, the number one thing that I hear about is access to care. But I also talk to providers in my district, and the number one thing I hear about from them is payment issues. Now, I think that we know the intent of the No Surprises Act was to address a practice of balanced billing that unfortunately decimated families' finances and limited access to care. But with the reports of a long and often arduous arbitration process, it's clear that there is more work to be done, as we're hearing today, and obviously as you know. And that's why we want to try to ensure that we are truly improving access and, of course, lowering cost. One of the lessons that I've learned in my limited time in Congress is that we can do a real good job of passing legislation, but we need the federal government to do an excellent job when it comes to implementing that legislation. And unfortunately, today, as to what we've heard and what we know, this is a good example of that not happening. Now, a key component of an effective independent dispute resolution process is timely payment by the losing side. Under the No Surprises Act, that payment is supposed to happen within 30 days. However, a recent survey by the Emergency Department Practice Management Association found that 87% of payers did not meet this requirement. And obviously, as you know, that threatens the financial stability of already stretched providers like the ones that I represent. Dr. Bleier, in your testimony, you mentioned the impact of slow reimbursement by providers. How do these delayed payments impact providers? And if you could, how do you feel? I know my colleague mentioned benefits, but how do you feel about the administration penalizing parties that don't pay within the required period?
Well, you know, it's been a structural loss for us, the way that this has been rolled out, unfortunately. You know, there's no way to claw back any of that revenue that we've already lost, unfortunately. As far as your comment on, or your question concerning whether there should be some type of penalty, whatever will ensure that, you know, the arbitrator rulings are followed in a timely fashion consistent with the legislation certainly seems reasonable to me. We're expected to make our payments up front as far as arbitration fees. We do that in timely. We're the ones where the onus, despite receiving an upfront payment, again, 40 to 70% less than what we've historically gotten for years and years and years, we're the ones where all the onus is on us to make that submission, to complete the paperwork, to complete the appropriate documentation. It seems only fair, I would, from my point of view, certainly, to expect that the other parties involved as well are held to a similar standard.
Great. Thank you, Dr. Bleier. Appreciate that. Mr. Chairman, thank you again. I yield back.
Ms. Malliotakis is recognized.
Thank you very much. Thank you, Mr. Chairman. Thank you to the witnesses. The No Surprises Act was a major bipartisan achievement, as was discussed from my colleagues on both sides of the aisle. But the goal was to protect patients from receiving these exorbitant bills from out-of-network care, often without their knowledge and consent. And the establishment of the independent dispute resolution, spearheaded by this committee, was designed to provide a fair mechanism for settling the payment disputes between the providers and insurers. However, as has been mentioned in its implementation, unelected bureaucrats have gone against the congressional intent and created a lopsided dispute resolution process which favors health insurers over the medical providers. Medical providers are now being forced to accept artificially low payments, leading to reduced staffing and exacerbating rural and underserved workforce shortages. I'm also continuing to hear from providers in my home state of New York that over the backlog of dispute resolution claims waiting to be resolved. Recent surveys find that 91% of filed IDR claims remain open and unadjudicated. CMS has recognized that the primary cause of delays in processing disputes has been the complexity of determining whether disputes are eligible for federal IDR process. They found that the health plan type was unknown upon dispute initiation in more than half the disputes, causing certified IDR entities to conduct additional outreach and further delaying the eligibility review process. I'll start with Mr. Bobek. Do you believe that there is additional information that could be provided that would help expedite this process and help providers determine claim eligibility?
Thank you very much for the question. Yes is the answer to your question. During the open negotiation process, this follows the process by which a provider has received a payment that they disagree with. They have a 30 business day open negotiation process. What is supposed to be happening during that process is the parties should be sharing that type of information. As an example, you mentioned parties don't know which health plan. If you are a TPA, let's say you are a TPA who represents several health plans, many self-insured funds, the provider themselves does not actually know who the health plan is. They just see the TPA, they see a name, and then they see other cases and they think that's all the same health plan. It is not. There are different ones. Parties are supposed to be sharing that type of information throughout the process. And the more that they share that, the more that they understand who they're dealing with and then those claims, we have seen it time and time again. It makes for a much better IDRE process. You don't see delays in those cases. You see timely and very quick adjudications.
And what portion is the backlog attributed to states like New York that have their own surprise billing laws already in place? And what is the current process for determining state or federal IDR eligibility?
When it comes to ultimately, right now, most of the cases are coming from other states as Texas. Texas, like New York, also has its own surprise building law as well, but that does not prevent cases still coming into the system that are not captured by that state process. When it comes to the backlog, again, we currently don't have one, but there is one that has been newly created simply by the portal not being open. And with the portal not being open, providers and payers cannot resolve their disputes and move forward. Ultimately, when it comes down to the state process and which state process applies, there are regulations, there are rules to which apply, but ultimately those rules are not always even clear to the parties. We always, again, has to say that we are like a judge. We can only go on the evidence as provided to us. The parties have to provide that evidence to us, as well as what we can find about whether a state process applies or not.
Thank you. Dr. Bleier, on that note, would including remark codes like CARC or RARC help to ease the current backlog?
I think it would. I think anything, again, that promotes transparency on the provider submission side would be incredibly helpful.
Okay. And Ms. Spicer, I understand you're a constituent of mine from New York. It's great to have you here. How has the experience been for patients in New York navigating both the state and the federal patient protections?
So in New York, we had our own system prior to the NSA. I think it took a couple of years to get it off the ground, and there are still issues with it. But consumers in New York now we have many consumers in New York, especially in New York City and the 5 boroughs that have self-insured plans, and the NSA applies to them specifically. They use those federal processes, and they appeal if they're not held harmless for surprise bills, and they're dealing with how to navigate those two at once.
So it's my understanding, based on the whole conversation today, that more transparency, more information, being more forthcoming with whether these are state or federal would be helpful in the matter, and also contributing to the high volume of claims moving through the IDR process is that there hasn't been a meaningful open negotiation period, which is supposed to help address these out-of-network claims. I thank you all for your time, and I look forward to working with our committee to address these issues.
Mr. Carey.
Thank you, Mr. Chairman, and Ranking Member Neal for bringing together, and all of you for being here today and going through this, the many hours of questioning. It's been enlightening. You know, the flawed implementation of the No Surprise Act has created burdensome and often confusing guidance for health care providers, including those that are in my home state of Ohio. This is leading to patients facing longer wait times, increased healthcare facility closures, and exacerbating workforce shortages, ultimately reducing access for those in the rural and underserved areas, particularly in my district. Today, we've heard from many of those providers who are impacted and see the harm caused by the poor implementation of the No Surprise Act. Dr. Bleier, my question for you: Congress created an open negotiation, 30-day period for payers and providers to settle the disputes before a third party would step in. How has this open negotiation design in the law worked for your practice, or maybe not worked?
So my understanding in discussion with our revenue cycle management company is that there has been effectively no response on any of the submissions from the insurers.
Interesting. Okay. Ms. Spicer, I want to compliment you on bringing up the name of one of the people in your written testimony who was a concert pianist and who had also, we had some time, I Googled her, and I would ask all my colleagues to do the same. She's very talented, but it really shows you the face of what happens to people that really you would think something like that would not happen to. Just have a couple questions. I have one question for you, but the No Surprise Act was signed into law in late 2020 to give patients the peace of mind that they won't receive a surprise medical bill weeks or months after they thought they were covered in a network service. Since the enactment, and some of my colleagues have asked this in a roundabout way, but since its enactment almost 3 years ago, how have patients benefited from this law?
Thank you for your question. Patients like Claudia have benefited hugely in being protected from out-of-network bills. Our New York state law would not have protected Claudia, did not protect Claudia, because it was based on network directory misinformation. She received her $35,000 bill. And the NSA does protect consumers against network directory misinformation. Also, thousands and thousands of consumers are held harmless for out-of-network emergency service bills as a result of the NSA.
So do you have any?
Air ambulance bills are also an inclusion that New York's law did not have.
So do you have any concerns that patient access to care, which is already in jeopardy due to the healthcare workforce challenges that we face, will be diminished due to the implementation of this law at all?
At Community Health Advocates, we see access to care issues every day. In my career of 24 years, I've always had clients who call me and say, I can't find a provider in my network that does a certain thing. It seems that if this process, the arbitration process, isn't fixed, that could be a result.
Thank you again. Thank you to the witnesses. And Mr. Chairman, I yield back.
I'd like to thank our witnesses for appearing here today. Appreciate your testimony and your several hours of endurance. Please be advised that members have 2 weeks to submit written questions to be answered later in writing. Those questions and your answers will be made part of the formal hearing record. With that, the committee stands adjourned.